Okay, hello. This is our substance abuse lecture. I hope that all you students have reviewed the first lecture I recorded. That was Psychosocial Theories in Biology. The chapter to concentrate on in that first lecture was Chapter 2 in Vedabek, which is Biological Theories and Treatments, which talked about neurotransmitters. You really have to know the big five neurotransmitters. That would be norepinephrine, dopamine, serotonin, GABA, and endorphins. The first three that I just mentioned are excitatory. They turn on the postsynaptic nerve, so they turn on the nervous system. GABA and endorphins turn off the nervous system. When you think of GABA aminobutyric acid, you can really think of Valium and alcohol. They both work on the GABA system, and that's the reason why alcohol and benzodiazepines, such as Valium, are sedating, because they turn off the nervous system. In other words, those neurotransmitters, GABA and endorphins, are inhibitory. They inhibit the nerve from firing. Endorphins literally means, as I think I've said in the past, endo from within, phene as in morphine. You have a morphine, heroin-like molecule in your brain. It is there to take the pain away in a crisis situation. Okay. Well, basics of substance abuse. Humankind has been using mind-altering substances since the beginning of recorded time. So substance abuse and drug use is not something new. But what happened, it became more prevalent in society in the late 60s. And this makes logical sense because what happened is when all the men came out of World War II in 1946, most men got out of the military in 1946, including my dad and my uncles. They got married and started having children. Well, those children, born in, say, 46, 47, 50, became teenagers and young adults in the late 60s. And we know that teenagers and young adults are risk takers. So that made the use of drug use in our society become more prevalent. And of course, it scared many, many parents. And there was a big rebound against drug use. But again, alcohol's been used for many, many years. Cocaine up in the Andes Mountains, marijuana. But it was the surge of youth using it that was the concern. And probably it's not a good idea for a young brain to be doing drugs. When humans are stressed, they will try to reduce their stress by healthy or unhealthy coping mechanisms. When people are stressed, they don't like that feeling. Your adrenaline goes up. You feel nervous and shaky, self-doubt. One way to deal with that would be a healthy way would be to exercise, to get that runner's high, go out and run a couple of miles, get in shape. But it may be easier, or what happens is you can't do that, so you sit home and you drink wine or maybe do other drugs. And if you do that long enough, you can become addicted. About 10% of the population is prone to addiction. And there's a genetic underpinning here. We're not really sure what the genes are yet, but we see a connection between drug addiction and bipolar disorder and or ADD or ADHD, um, hyperactivity disorder. Because many times bipolar and this hyperactivity disorder, ADHD, have an impulse control problem here. An impulse control disorder means that you know you shouldn't be doing this, but you cannot control your behavior to not do it. Okay. Drug addiction is a physiological, psychological, and spiritual illness. Physiologic means it affects your body in biological ways. Psychological, it affects your psychology. And it's spiritual in the sense that that drug, when you're addicted, it becomes your God. Everything that you worship that drug, your life revolves around that drug. And that really is the definition of addiction, that you can't stop despite knowing you're hurting your body, you're doing things that are going to hurt you. You simply can't stop. And I've heard drug addicts say, one heroin addict said to me, heroin is better than life itself. I mean, that statement alone is just incredibly sad. A basic tenet here, whatever effect a drug has while under the influence, the opposite will occur during acute abstinence. So if alcohol tends to be sedating, making you tired, In withdrawal, you will be nervous and shaky. Okay? If cocaine wakes you up, in withdrawal, you're going to be sleepy. And that makes sense because basically what's happening here is you're elevating these neurotransmitters in your brain. Say in the case of cocaine, those neurotransmitters would be dopamine and norepinephrine, serotonin to some degree. You elevate them, you feel great, you're hype, you're happy, have a good time, life is great, and then you run out of them. So you go into a depression. So it's an opposite effect. When people start using drugs heavily, they stop maturing emotionally. So when people at the age of maybe 14, 15, or 16 start smoking marijuana heavily or alcohol or drugs, heroin, whatever, they stop maturing emotionally. What do I mean by that? Every time someone is frustrated, they go get high. So they never learn how to problem solve. So they actually stunt their emotional growth. An emotionally mature person can tolerate anxiety, ambiguity, and make appropriate choices. But the person who's doing drugs heavily doesn't do that. They just keep getting high. So basically, what can happen here, if you work in a drug rehab, and you students that are going to be going in there very soon, and the students coming in a few months, when you work in the drug rehab, you will actually see 45-year-old men or women that have the emotional capacity of a 14-year-old. They fight over a cup of coffee. They get in arguments over little things. You have my chair, get out of my chair. They don't share. An adult human who is mature shares. Oh, there's one cup of ice cream. You can have it. It's okay. Children don't do that. So we can actually see people that are much older but act in a very, very mature way. Through the drug rehab, what we try to do is advance their maturity up to their chronological age. Well, how many of you notice yourself smoking more cigarettes or using more alcohol since beginning nursing school? Why? I ask this because people tend to self-medicate when stressed. All drug use, including coffee and cigarettes, is self-medication. You wake up in the morning, you want to wake up more quickly, so you have a cup of coffee. That night you went to work, you're all revved up from work, you had a stressful day, and you have a glass of wine. This gone beyond a glass or two of wine or beer, or any alcohol for that matter, done enough, you can become an addict. Okay? But again, some people, about 10% of the population, are genetically prone to addiction. Many people that go to high school in America go through a phase of probably drinking beer and wine or whatever, and most of us grow out of it. What makes the 10% of those people get stuck? And there's a genetic component, and many times there's childhood trauma. Okay. The healthy way to handle this stress would be to study harder or exercise, but you probably have little time for that. So it's more effective, more time effective to use what I have coined the term passive recreation. Get off the couch and go ride your bicycle takes effort. You're tired, you worked all day. So it's easier to passively recreate. Just sit on that couch and drink wine. And funny thing is, the same neurotransmitters that are released when you exercise many times are released when you do drugs. Except exercise, you've earned it. You've went out and spent calories. You've earned the good feeling. You've earned the runner's high. When someone sits on the couch and just drinks alcohol, they have not earned it. Okay? In fact, many times patients will ask me when I give lectures, what can I do to achieve the feeling of doing crack? And my response to that is nothing will give you that feeling, because that feeling is not natural. But something close to that would be the runner's high. People that run a lot or exercise get this feeling of elation after the exercise, and that feeling of elation is due to adrenaline, endorphins, some dopamine, things like that. Okay, let's look at some key terms. A blackout, basically a blackout is when people either do alcohol or benzodiazepines, or for that matter, any medication that excessively elevates GABA, aminobutyric acid. When you elevate GABA, remember, that's an inhibitory neurotransmitter, you turn the brain off, and you turn off the memory part of the brain. So basically what a blackout is that your body is fully awake and functioning, but you have zero memory of what you did. It may be something like this. You go out partying with your friends, you're partying, you go to sleep at 3 in the morning, you wake up, um, and your friends call you the next day and say to you, "You were so funny last night, you were so funny." And you start to say, I don't get it. What do you mean I was funny? The jokes you were telling you were so funny. And you have no recollection because the GABA that you elevated from your alcohol or benzodiazepines has shut down the memory part of your brain. Also might appear that you go out partying, you meet somebody at night, you bring them home to your house, or you go to their house, you may have sex, and you wake up in the morning and you look across the bed and you say, how did this person get here? I don't recall getting in bed with this person. You are in a blackout. So blackouts are very, very dangerous because a person has zero memory of what they did. In fact, there are cases in law where someone has murdered somebody. They said, no, I didn't do that. No way, I didn't do it. And there's a videotape of them murdering that person. Blackouts are not good, and they are an indicator that someone's on their way to addiction. Tolerance means you need to do more and more of the drug to achieve the same level of feeling. Okay, as you get tolerant, you need more and more of the drug. A tolerance break is when you stop using the drug for any period of time, usually would be a couple of weeks to a month, where your tolerance goes down. So now you need less of that drug to get high. Also, a tolerance break could be related to an alcohol to your liver, because liver alcohol in higher doses kills the liver. Well, the liver is what gets rid of alcohol. So if you're killing your liver with alcohol and the liver is dying, it's unable to clear the alcohol out of your system. So you lose tolerance because the alcohol level in your blood stays higher. Okay? So tolerance is you need more of the drug to achieve the same effect. Tolerance break, you need less. Well, another thing that can happen with tolerance break when you lose your tolerance, and one of the biggest problems we have in rehabs is patients come into a detox. They're in the detox for, say, heroin for 3 days or so. We transfer them over to the rehab ward. They go to the rehab ward. They spend 28 days there. Over this month or so of sobriety, they lose their tolerance. And they leave the rehab, and this is what they say to themselves. And I've heard this many, 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 many times. I did great in rehab. I need to reward myself one more time to get high. I'm just going to get high one last time because I need to reward myself. They go back to doing the 10 bags or 12 bags of heroin they did when they went into rehab. But remember, they've lost their tolerance for that dose. Shoot up their 10 or 12 bags, and in the case of heroin, you fall asleep and you die. Very, very sad. Okay, sobriety is not doing drugs and alcohol. Relapse is going back to doing drugs and alcohol. Dependence can be both physical and psychological. For example, we say basically that is defined by what you manifest in withdrawal. A drug with physical dependence, alcohol and heroin. When you stop doing that drug, you have physical symptoms of withdrawal. In the case of alcohol, those symptoms would be anxiety, possible seizures, elevated blood pressures. In the case of heroin or any opiate for that matter, you'll feel like you have the worst flu you've ever had. You won't die. You don't die, generally die coming off of opiates. You may wish you were dead because the withdrawal is horrible. But basically, coming off of opiates, provided you've been addicted to them, you have a flu-like withdrawal. So those are drugs that give a physical withdrawal. Cocaine, on the other hand, when you come off it, you don't really have physical symptoms of illness, but you feel depressed. You feel depressed, life is not worth living. Well, the quickest way out of that withdrawal is to go get more cocaine. Or the quickest way out of the heroin withdrawal, the flu-like symptoms, is to do more heroin. Or in the case of alcohol, shaky, sweaty, seizing, do more alcohol. And this is what leads to chronic relapsing, is people feel so miserable in withdrawal, they cannot tolerate that feeling, go back and do the drug again, and again. Okay. Detoxification. Well, alcohol is a toxin, intoxicated, toxic. So they call the ward that gets people off drugs and alcohol that originated to be used for alcohol withdrawal, the detox ward, the detoxification ward. And alcohol is poison by nature. What do we do when we give someone an injection, an IM injection, maybe in their arm and their leg? Is we first clean that site with alcohol. Alcohol cleans the germs. The skin is cleaner. Well, alcohol will also kill our cells, but we need a much higher dose to do that. They say that the female person can drink 1 drink a day with no real physical damage. A man can drink 2 drinks a day. But as you go above 3, 4, 5, 6, 7, 8, maybe 10, 12, what more than that even, your body, your liver can't get rid of it quick enough. And there it stays in your body, and it can kill the liver cells, it can kill brain cells, other cells in the body. Okay? Let's talk about half-life. The half-life of a drug is the amount of time it takes to clear half the drug out of your body. And the liver is the general metabolizer of drugs, although other organs in the body metabolize drugs also. Half-life is the amount of time it takes to clear half the drug out of your body. A drug with a longer half-life means that you have to dose less often, both with illegal drugs and legal drugs. For example, if someone was taking Xanax, it's a benzodiazepine known as alprazolam, taking that for anxiety prescribed by a doctor, he might write something, take 1 pill every 4 hours. And you get the full effect after about an hour. It would last 2 or 3 hours. It would slowly come out of you. You go into a little, you lose it out of your body. You get anxious again, you take another dose. If the doctor prescribed Klonopin, which is also a benzodiazepine, very, very long acting, it's got probably about a 12-hour half-life, you can take that medicine twice a day, once in the morning and once at night. So the longer the half-life, the longer the interval in between dosing. The ceiling effect. The ceiling effect means that no matter how much more of a drug you do, you really don't get that much higher. Marijuana tends to have a ceiling effect. You could smoke a little bit and get to a certain point. You could smoke much, much more and not have that much more of an effect. Coffee tends to have a ceiling effect. You have a cup of coffee, maybe 2 cups, and even if you drink 3 or 4, you're not going to get that much more of an effect. You might get a little more nervous. Okay. Heroin, on the other hand, its ceiling effect is death, because you'll keep doing heroin, and eventually you do enough heroin being inhibitory, because it mimics the neurotransmitter endorphin in your brain, eventually turns your brain off, which means your brain cannot tell your lungs to breathe, and eventually you die from respiratory depression. So a ceiling effect, you hit the ceiling and can't get any higher. That would be marijuana and maybe caffeine. Heroin does not have that. Enabling. Let's talk about enabling. Enabling is when a person in a relationship helps that person to continue their addiction. A classic story here. And just to let you know, there are more men addicts than women. That is probably because men are risk takers, and that is due to testosterone. Anyway, so you have a husband and wife, and the husband's watching the football game on a Sunday evening, and he's drinking beer after beer after beer after beer. He's drank 8 beers, and he's pretty slogged, and he goes to bed at, 12:30 at night. You got to get up for work at 5 in the morning. Tells his wife, I can't get up. I just can't do it. I don't feel good. So the wife says, don't worry, honey. I will call your boss and tell him that you're sick. So what the wife has done is enabled her husband to continue his drinking. She's enabling him. Now, she may think that she's helping him. Oh, I'll help you, honey. Don't worry. But in reality, she's allowing this addiction to continue. He is considered codependent upon the drug that this person was using. Codependent, indirectly dependent upon the alcohol in this case. Dual diagnosis, also called MICA, mentally ill, chemically addicted. So dual diagnosis means the person has a psychiatric disorders such as anxiety, depression, maybe schizophrenia, and also has a substance use disorder called dual diagnosis or MICA. There's another term to describe it also, which I'm forgetting right now, but I think you get the point that it involves two mental disorders at one time. Designer drugs. Designer drugs are drugs that are made in somebody's home laboratory that have very little, if any, quality control. In other words, if someone is getting opiates from their doctor writes a script, the person has a bad back, they go to the pharmacy, they get some OxyContin. The OxyContin is made in a very controlled lab that is restricted and very few impurities. That's quite a pure drug. Designer drug could be someone has a home lab and they make synthetic heroin. Synthetic. It's not made from the poppy plant. They've found a combination of chemicals that can mimic it. Ecstasy is a designer drug. In other words, it's made in clandestine laboratories in people's homes. And many times they don't have a biological plant base. Opiates, generally, or heroin, morphine, comes from the poppy plant. Marijuana comes from the marijuana plant. It's made in laboratories that are regulated for cleanliness and things like that. Many designer drugs don't have that. In fact, there is a story about 20 years ago, I believe I read it in Time magazine, where there was a gentleman in Florida and he made synthetic heroin while he was using his Bunsen burner, the flame, to heat up and change the molecule. He overcooked it, altered the molecule. He didn't really care. Sold this drug on the street as heroin. People injected it into their arm and froze immediately. What happened here is that drug went to the substantia nigra part of the brain. That is the part of the brain that produces dopamine. It destroyed it. When you don't have enough dopamine, you get an illness called Parkinson's disease, which means your muscles seize up. These people, to this day, I have recently read about them, are still Parkinsonian patients. Again, designer drugs have no quality control. Let's talk about cross tolerance here. Cross tolerance means if you're tolerant to one drug, you will be tolerant to another drug that has a similar mechanism of action in the brain. The classic example here is benzodiazepines and alcohol. If someone drinks alcohol very heavily, and this is what occurs in the detox unit, which we'll be going to, they drink alcohol very heavily, they become tolerant to benzodiazepines, and those are Valium, Klonopin, Xanax, Ativan, because alcohol and benzodiazepines work very, very similarly in the brain. So what can happen in this case is the person comes in for alcohol, they're drinking a case of beer a day or, 25 shots of whiskey a day, whatever. We put them on a benzodiazepine. We replace their alcohol with a benzodiazepine. Again, works very similar. And we titrate the dose downward as their brain heals. But these people that were drinking very heavily can tolerate massive doses of benzodiazepines. In fact, I worked in a hospital. A patient came in, a very, very heavy alcoholic. He ended up getting about, I think I heard, upwards of 800 milligrams of Ativan in 24 hours. Let me explain to you. The normal dose of Ativan for anxiety, which is usually prescribed for, is 1 to 2 milligrams every 6 to 8 hours. So that would mean you would average of 6 milligrams over 24 hours. This man was so tolerant to alcohol, which made him so tolerant to benzodiazepines, that he needed massive doses of Ativan to keep him from having a seizure. That is the biggest fear we have in alcohol withdrawal. We'll talk about that in a few slides. Denial. Denial is an ego defense mechanism that addicts use, especially in early sobriety, to deny they have a drug or alcohol problem. For example, patient says, the cops always pull me over, they don't like me, they just don't like me, so they pull me over. Mr. So-and-so, you have 5 DWIs. That's because they don't like me and they just pull me over. It's not because I'm not an alcoholic. The cops just don't like me. When someone has 5 DWIs and they're not admitting they have a drinking problem, they're in denial about that. Someone can have 1 DWI and hopefully they learn their lesson, never, ever, ever to do that again. But when you have 2, 3, 4, 5 DWIs and you don't believe you have a drinking or drug problem, you're in denial. Okay? Our job as psychiatric nurses that work in detox is to gently have them realize that this denial is what they have, that they are addicts. And as I've said before to some of my students the other day, there's no shame in mental disorders. Mental disorders aren't bad. People with mental disorders can do bad things. But it's part of the human condition. We are humans. We suffer from physical disorders and we suffer from mental disorders. Our job as mental health professionals is to help people get well from their mental disorders. Okay, polysubstance use. Well, maybe up until 30 or 40 years ago, you many times had just alcoholics and they went to AA, and you just had heroin addicts and they just went to Opiates Anonymous or Narcotics Anonymous. Now, pardon me, there's a motorcycle going by on my road, excuse me. Now it's more common to see alcoholics that also do cocaine, heroin addicts that also do cocaine, people that smoke marijuana and drink alcohol. So now many of the patients that come through the hospital are polysubstance abuser. In other words, they're abusing more than one substance. So let's talk about the DSM. Currently, we are at the number DSM-5. This is the definition as per the DSM-4. Not that much has changed. Substance abuse, this is the section of the DSM. Substance use has interfered with a person's life in one of the following areas. Failure to meet role obligations. In other words, you're going out getting high so much, you're not going to work, or you're not taking care of your children or paying attention to your wife. Recurrent use in physically hazardous situations. Recurrent. In other words, 1D where you learned your lesson, but you can still continue to drive impaired. Interpersonal problems. Again, you're not paying attention to your wife or your significant other because you're too busy getting high. You have legal problems. You have a DWI related to substance abuse. Okay? That is substance abuse. Substance dependence. A maladaptive pattern of use leading to distress in 3 of the following areas. Probably includes abuse criteria also. You get tolerance. In other words, you need more and more of the drug to achieve the same effect. If you try to stop, you have withdrawal symptoms. You find it very, very difficult to cut down because, one, you don't want those withdrawal symptoms. Also, your brain has been altered and now needs the drug. You spend much time on drug-seeking activities. Your recreational activities that you used to do are now replaced by drug use. You use drugs, you continue drug use despite known health risks. It can be said that anybody that smokes cigarettes has a mental disorder of substance dependence because we now know that cigarettes will harm you in the long run. You may not know that when you're 19, but when you hit 60, 65, 70, 75, if you've smoked all those years, there's a very good chance that you're going to have some health risk caused by cigarettes. So anybody who smokes cigarettes could be considered mentally ill. Again, this does not make you bad. It makes you human. It's part of the human condition. Epidemiology. 14 million Americans, and epidemiology means numbers and statistics related to, in this case, substance abuse. 14 million Americans abuse illegal substances. Okay. My feeling is it's much, 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 much higher than that. Most people do not admit that they smoke marijuana. Most people do not admit that they do heroin or cocaine or other drugs. Highest among men in their early 20s. And this makes logical sense because testosterone is quite high in the early 20s. Testosterone makes men risk takers. Okay. And the early 20s is a very social time. You know, testosterone is, when you go down Nichols Road, for instance, or maybe the LIE, you will see crosses on the side of the road sometimes. I can guarantee you 95% of those crosses are for men between the ages of 17 and 25. Because in that age group, you have a lot of testosterone, a lot of aggression. You don't think you're ever going to die, and you do 120 miles an hour, and you lose control of your car. Okay? Well, in evolutionary sense, that does make sense, because when your body is at its physical peak between the ages of, say, 17 and 25, you should be the hunter that goes out and hunts the buffalo to bring it home. A 50 or 60 or 70-year-old man does not have the physical ability or the endurance to go out and hunt. So it kind of makes sense that a person of that age, 18 to 25, would have tremendous physical ability, but not a lot of common sense. And that lack of common sense has been found to be related to that the frontal lobe, which controls behavior in our brain, the frontal lobe in our brain, is not fully myelinated until about 25. The myelin is the fatty covering over the nerves. The myelin allows the electrical impulse within the nerve to travel more quickly. So if a nerve is not myelinated, it can't communicate with other nerves in a very fast manner. So you do an action without actually processing it, the consequence of that action before you do it. Okay? So it's highest among men in their early 20s, probably related to testosterone, which increases risk-taking behavior. Rates of abuse is steady amongst ethnic groups. This is not a white, black, yellow, upper class, lower class, middle class illness. All strata of society and cultures of society have pretty much equal drugs of abuse. 104 million Americans use alcohol, highest amongst college grads. 66 million use tobacco, lowest amongst college grads. Boy, that's kind of interesting, isn't it? People go to college and come out of college drinking more alcohol. Okay? People come out of college drinking less cigarettes. What could be going on here? Well, children at home living with their parents, they graduate high school, they move away to college. Most kids want to go away to college, and they're free now. They're free, they're free, they're free. And they drink. So drinking alcohol is a rite of passage of going away to college. And remember, their frontal lobe is not fully myelinated. So they're making decisions without a good brain to control that behavior. But let's look at tobacco. Smoking tobacco has gone down tremendously in the United States over the last 50 years. I believe in the 1950s, 40s or 50s, it was 50% of Americans smoked. Now we're at about 15%. What caused that? Well, I can tell you in the early 1970s, prior to, I think it was probably 1972, cigarette companies were allowed to advertise on TV. There was the Marlboro Man, menthol cigarettes being advertised, and people got advertised, so they smoked. And then in the early 60s, we began to realize, the Surgeon General realized, that cigarette smoking is detrimental to health. So they got together and passed a law saying no advertising of cigarettes on TV. Over the last 10 or 15 years, actually, we have seen these commercials on TV. One of them I remember distinctly, of a man who had a tracheotomy and had to breathe through a hole in the lower part of his neck. And he says, I can no longer swim. I smoked and I got cancer of my esophagus, and I can no longer swim because the water will go into the hole in my throat. These are very, very powerful messages. So what we're seeing here is education works to prevent drug use. We have educated people that cigarettes are not healthy. Advertising them on TV is not allowed. There is no smoking in buildings now, and we have seen the rate of smoking go down. On the other hand, in college, alcohol is everywhere. Alcohol is everywhere. Okay? So the moral of that story is education is the key to reduce drug use. Not putting people in prison. That does not do that. That just makes them angry. Okay? The key here is education. Early education. Let's talk about some ideologic theories. Ideology means causation. Let me make it clear that drug use or alcoholism is not due to a moral weakness. Up until about 1967 or so, it was thought to be a moral weakness. In fact, I gave one of my students a task to investigate how this came about, and I should have kept this paper she gave me. She, under, I believe it was Richard Nixon, or maybe it was Johnson, he commissioned a psychologist to do research into addiction. And this psychologist came up with drug addiction is due to a moral weakness. Our job in drug rehabs is to humiliate these people to a lower level of functioning. In other words, make them a child and then rebuild their personality. That is a bunch of nonsense. Okay. We now know that there is a very strong biological component to addiction. In other words, if one of your parents has an addiction problem, you have a pretty good chance that you may have one. Let's take a look here. Strong evidence of genetic influence. If one identical twin has addiction, 50% chance another twin will have an addiction also. No genes identified as of yet, but we're honing in on the genetics of addiction and other mental disorders. We're not there yet, but we'll be there in about 50 years, I suspect. So it is heritable. It is inheritable. It is genetic. It does not mean it's 100% correlation that if one of your parents or both of your parents have addiction, that you will definitely become an alcoholic or a drug addict. But it makes the chance easier. The only way to guarantee that someone will not become a drug addict or an alcoholic is to never, ever do a drug or alcohol. Because for some people, once they try it, they've triggered the gene or genes, and now to not go back and do it becomes very, very difficult. Psychological environmental factors of addiction. Poor parenting. Inconsistent parenting, where a child cannot predict a parent's mood and the parent is psychologically unstable, can make a child very anxious. Lack of nurturing from a parent. Poor coping skills demonstrated by a parent. A parent comes home from work, had a bad day of work, and gets drunk. Well, a little child says, well, when daddy had a bad day, he drinks alcohol. So when that child grows up, they learn, when I have a bad day, I'll drink alcohol. Again, the right way to handle this would be to exercise, something like that. If a family member is doing drugs and alcohol all the time, children learn that. Children are sponges. Children look at their parents and mimic their behavior. Okay? Again, there's exceptions here. Children can grow up and say, I saw my father being an alcoholic. I will never do that. Okay, but they've learned. But many times we mimic what our parents do. We mimic our parents' coping skills. Psychological trauma. Well, PTSD leads to self-medication. If you were in Vietnam and you saw your buddy get blown away right next to you, one second you're talking to him, the next second he's gone or dead next to you bleeding, that is tremendously stressful on you. Okay? And someone you're in Vietnam and someone says to you, here, try this little white powder, it'll calm you down. A little side note here. Vietnam, that area of the world, was considered the golden triangle of heroin production during the Vietnam War. In other words, much of the heroin in the world was produced in the Vietnam area. So we sent our men to Vietnam. They were in guerrilla warfare. In other words, during World War II, there were direct lines. The Allies were here and the Germans were on the other side. There was a direct line. Guerrilla warfare is the enemy can be mixed amongst you. They could be ambushing you. They could be acting as a civilian and then pull out a gun and blow you up. In fact, I've heard stories of a child walking up to the GIs, pulling a cord, detonating himself with explosive, and wiping out many GIs. Well, now the problem is the next time a child walks up to you, what do? Do you shoot him first? Or do you say, let me get to know him? Well, If the day before you saw your buddy killed, you might just say, let me shoot this kid before he detonates that bomb. And you do that, and then you look at his body, and there's no bomb there. So now you have guilt. Well, take a little bit of this powder. It'll get rid of that guilt. So very, very difficult situation in Vietnam and in any war, okay? But PTSD and trauma can make us self-medicate because medicines can reduce our symptoms. Again, not much different from having a bad day at work and having a glass of wine when you get home, okay? And a little sidebar here again, I always see Vietnam as a very unfair war. If you went to college, you got out of Vietnam, as did President Clinton, President Bush, President Trump, probably several others, because you were deferred. And if you kept deferring by going to college, you didn't go to Vietnam. Also, if you were arrested, many times the judge would say, son, you've been arrested. Either you go to jail or join the military and go to Vietnam. Most young men would say, hell no, I'm not going to jail. I'll go to Vietnam. My dad was in World War II. He wouldn't let me go to Vietnam. Vietnam was not a fair selection process. Oh. The stress of adolescence. Adolescence is a very stressful time. Adolescents are figuring out, who am I? Good, bad, gay, straight, black, white, all these decisions. Where do I fit in society? That produces anxiety. Well, drugs, alcohol, benzos, opiates will decrease that anxiety. Okay. Underlying mental illnesses. Okay. You have an anxiety disorder and you don't really realize how bad it is. You start to drink alcohol to get rid of anxiety. Alcohol will decrease anxiety. It will do that. Okay. Or you have a psychotic disorder. Alcohol will dampen the voices that you hear. It won't get rid of them. It'll dampen them. You know, I was working in a hospital and a patient came in. He was a heavy alcoholic and the doctor offered this patient Prozac. He said, I'm not taking Prozac. No way, I'm not taking Prozac. So I sat with him, as a good psych nurse should do, and I sat with him and said, Mr. So-and-so, you have an anxiety disorder. You've been medicating with alcohol. Alcohol is a drug. Yes, it is a drug, but it was a drug that we used during the Civil War. This is the year 2003. We have much better medicines for anxiety now. So you're medicating with a drug that's 150 years old. Why don't you try the modern drug Prozac? No, 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 I don't want to try it. Why don't you try it for a week? You can always stop taking it. Try it for a week. All right, Mike, I'll try it for a week. Just for a week, though. Takes it for a week. I'm back. How you doing, Mr. So-and-so? I'm feeling really good. So do you want to continue to take this medicine? Yeah, I'll take it. I really feel very good. This medicine's helping me. That is good psychiatric nursing. Find a way to win them over and educate them so they will take the prescription that the physician or the nurse practitioner has prescribed. Here's perspective on addiction. Psychoanalytical and psychodynamics. So this would be Freudian type therapy. Freud, if you lay on the couch and free associate, it is psychoanalytical. If you sit on the couch facing your therapist, it's psychodynamic. But the key to Freudian therapy is free association. Freud tried to hypnotize people, but not everybody can be hypnotized. So he came up with this: lay on the couch, I will sit behind you, and I just want you, the patient, to talk about any thought that comes to your mind. Randomly. If it's random, just speak it out, blurt it out. That's called free association. And actually what happens when the therapist does this is over several weeks or months, depending upon how often the patient comes to the office, the therapist can identify a theme. Gee, Mr. So-and-so, you've been coming here for about 6 months, twice a week. I've noticed many of your verbalizations seem to indicate that you may feel inferior to others. Patient says, gee, I guess you're right, doctor. I guess you're right. I do tend to feel inferior to others. Next thing the therapist would probably say is, talk to me about your childhood and your relationship with your mother and your father. Many of the themes we have, in fact, I just told my last group this past Thursday group, all of us are products of our childhood. personality we have is an integration of our genetics and our upbringing by our parents. Okay? So this patient may say, yes, I guess I do feel a little less than others. And the therapist would then investigate what brought on, what interactions with his parents made him feel less than. Other themes could be superiority. That would be common in narcissistic personality disorder and possibly mania and bipolar disorder. Okay. Anyway, that's a little background on Freudian therapy. When you think of Freud, think of feelings. Freud felt that all thoughts were derived from feelings. Okay? He felt drugs may calm a harsh superego, possibly caused by childhood psychological trauma. Okay, so if you're traumatized and you have a harsh superego, again, the superego is be good to others, do unto others as they shall do to you, be a good boy. The other part of this Freud theory is the id and the ego. The id, we can think, is the kid. I want it, I want it now. I don't care about the consequences. I just want a party. The ego sits in between the id, the kid, I want it now, and the superego, which is your moral compass. Be good to others, delay gratification. Okay? Well, if you have a harsh superego and your superego is always telling you, don't do that, you hurt somebody's feelings, don't do that, be a good boy, don't do that, don't do that, you get very nervous. A little bit of alcohol, a little bit of benzo, a little bit of heroin, or possibly cocaine can reduce that harsh superego. Okay? Freud also felt that drugs taken orally may satisfy unmet needs of oral stage of development. He felt that people that smoke cigarettes did not satisfy the oral stage of development. Again, most of you should have taken a basic psychology course and know that Freud studied, uh, psychological development, the oral stage, the anal stage, things like that. I don't know if I totally agree with that, but I do agree with the concept that if you have a harsh superego, drugs like alcohol will decrease the anxiety caused by that superego. Well, another type of therapy is called cognitive behavioral therapy. Basically, that's based on learning. And the fathers here of these therapies are Beck, Burns, and Ellis. And there's a very famous book called Feeling Good. Again, I'm not seeing you guys in person. Normally bring that book into lecture. And they feel, in this theory, that your thoughts produce your feelings. So they think a little bit opposite than Freudian therapists. Freudian therapists feel that feelings produce thoughts. And I would say there's no right and wrong. Although I have to lean toward Freudian therapy because I know if I don't get a good night's sleep, I feel miserable and I tend to have negative thoughts. And I think some positive thoughts and make my feelings be better? Yes, but it's very, very difficult. Cognitive behavioral therapy. And cognitive behavioral believe cognition meaning thoughts and behavior meaning behavior. Poor role modeling by parents. In other words, once again, your parents are showing you behavior that is poor behavior. It's poor role modeling. Children mimic parents' behavior. If a parent smokes, a child looks at their parent smoking and says, gee, daddy smokes, therefore I'm going to smoke. Okay, that's behavioral. Also says the pleasurable effect of drugs outweigh the negative consequences. Drugs serve a purpose in people. They make people feel better temporarily. They don't solve any problems, but they make people feel temporarily better. If they made people feel worse, people wouldn't do them, right? Okay. And the pleasurable effect of the drugs outweigh the negative consequences. And that may be true with a glass of wine or a beer. You go on 2 drinks a day, or high levels of drugs, you're going to get negative consequences. You're going to wake up with a hangover. You may end up getting addiction in the future. Okay? Pharmacodynamics. And pharmacodynamic means how the drugs exert their effects. Most drugs must interact with a receptor to work. That's why you must know chapter 2 in these receptors. Okay? Therefore, the body must have and endogenous, endo from within the body, substances with similar molecular structure, and we do. There's a drug called morphine, pretty much similar to heroin, and we have a morphine-like molecule in our brain. It is called endorphin. Endo from within, morphine. It's a hyphenated word, endorphin. So the heroin or the morphine can go to that endorphin receptor and activate it. Well, up until about 1987, they were not sure how marijuana worked. They thought it might be GABAergic because they knew it calmed people down. They thought it might be serotonergic because serotonin can calm people down. In about 1987, 1988, a physician, I forget his name, I once knew it, found a receptor on a cell that marijuana bound to. That receptor was not put there for you to smoke marijuana. Well, if there's a receptor there must be an endogenous substance in your body that also binds to that receptor, and they are called endocannabinoids. Okay? So in most cases, drugs of abuse and drugs that we give patients to help their mental disorders, antidepressants, antipsychotics, bind to a receptor. Dopamine is the primary neurotransmitter responsible for psychological addiction. Dopamine has several functions. It is the central pleasure neurotransmitter. It is a neurotransmitter that is involved in movement and coordinating muscle movement. It also is the neurotransmitter that if you have too much of it, you can become paranoid and psychotic. Okay. But when people get high, what they're trying to do is elevate their dopamine to get that warm, funny, pleasurable feeling that life is good. Okay? Dopamine and endorphin are the brain's natural reward and pleasure system. Most drugs of abuse elevate dopamine. Dopamine is the central neurotransmitter responsible for psychological addiction. It gives you pleasure. Know that. Okay, so let's talk about specific classes of drugs, stimulants. But before I do that, I'm just going to take a break here to draw a synapse. I'm not sure if I have it in this PowerPoint anywhere, so let me see if I can draw one very quickly. Just give me 2 minutes, and we're going to show it to you. Okay, can you see that? I'm not sure if you can see that very well, but let me see if I can rearrange this. Well, it's going to be hard to see. Well, I don't think that's going to work. Let's go back to here. So you have a presynaptic cell. Every cell is both presynaptic and postsynaptic. The impulse comes in from the dendrite, receives a message, a chemical message from the other cell. That chemical messenger, in this case, we'll call it dopamine, hits a receptor on the dendrite. The dendrite turns on, that chemical turns on that dendrite to propagate electricity down the dendritic pathway to the nerve cell body. The nerve cell body processes that impulse and possibly sends out another electrical impulse down the axon to the synapse. When that electrical impulse gets to the end of the synapse, it gets to the axon terminal, it releases neurotransmitters that go across the synaptic space, diffuses across this microscopic space, probably the 100th of the width of a human hair, maybe less than that even, that if that neurotransmitter hits a receptor that's made for that neurotransmitter, it can turn on or turn off the postsynaptic nerve. Okay? Do this again. Dopamine, when it hits its receptor on the postsynaptic nerve, turns on that nerve. And that nerve gets turned on. And all the nerves down that pathway get turned on. Adrenaline or norepinephrine turns on nerves in the same way. Serotonin can turn on nerves and turn off nerves. So I look to think of serotonin as both excitatory and inhibitory. GABA, aminobutyric acid, and endorphins, they turn off nerves. When they hit their receptor, they prevent the postsynaptic nerve from firing. That's what makes heroin, endorphin, morphine, and GABA, which is basically like alcohol or benzodiazepines, calming. That's the way they calm you down because they turn nerves off. Well, after that neurotransmitter hits a receptor in the synaptic space, we don't want to leave that neurotransmitter there all forever because it'll just keep hitting that receptor. So the body I like to think God and nature are the one and the same thing, put a little pump on the presynaptic nerve, the nerve that originally released this neurotransmitter, to suck that neurotransmitter back up, to store it back in the axon terminal, to await another electrical impulse to release it. Okay? So that's basically the way it works. I urge you to look at chapter 2 in the book or go online and type in the synaptic space, and you'll probably get a diagram online that describes what I just said. Okay, let's go back to stimulants. I have grouped all stimulants together, meaning amphetamines and cocaine. They act by causing a massive release of excitatory neurotransmitters and then block their reuptake in the postsynaptic nerve. Those excitatory neurotransmitters are adrenaline, dopamine, and serotonin. Street stimulants crack is a form of cocaine, and I'll explain why it's different in 1 minute. Methamphetamine, known as crystal meth, ice, speed. And then there are prescribed stimulants such as Ritalin, dextroamphetamine, things like that you can get for your psychiatrist. Many times these stimulants are prescribed for children or adults with ADD, and that means attention deficit disorder. Well, again, why would you want to give a person who's hyperactive a stimulant? Because when the stimulant wakes up, remember the frontal lobe, the part of the brain above our eyes is the frontal lobe, just beyond the forehead bone here. People that have ADD or ADHD, that frontal lobe cannot regulate their behavior. Well, the frontal lobe, if you remember from our last lecture, has to do with executive functioning, paying attention, planning ahead, controlling behavior. Well, if your frontal lobe is not awake, you cannot plan ahead very well. You cannot concentrate very well, and you cannot control your behavior very well. If we give this person a stimulant, low dose, goes to the frontal lobe, releases adrenaline, dopamine, and serotonin, wakes up the frontal lobe, and now this child or this person with ADD or ADHD can concentrate, can plan ahead, and is said to have better executive functioning. Executive, in other words, planning ahead, things like that. Okay. Well, let me go back to crack. Crack is a form of cocaine. Basic cocaine is powdered. Basic cocaine does not burn very well. In about 1987, again 1988, somebody figured out how to make cocaine burnable. Well, you used to take cocaine, people would take it and put it up their nose, snort it, put it up their nose, and someone get into their brain and release adrenaline, dopamine, and serotonin. Well, now that you've converted this powdered cocaine to a smokable form that is called crack, now that's burnable. That means you can smoke it. Well, you put it in a pipe and you smoke it, and it goes into your lungs. So here is the difference. The surface area of someone's nose, I have a pretty decent Italian nose, is very, very small. In fact, if you took the surface area of my nose, excuse me, this is a truck going by now. If you took the surface area of my nose and laid it out one cell layer thick, the surface area might occupy the size of a coffee table or a desk. If you took my lungs and spread them one cell layer thick, of course you could never see one cell layer, the surface area could be somewhere between a tennis court to a football field of surface area. So when you smoke a drug, you expose that drug to so much more surface area to be absorbed. It can get so much more to the brain. So crack is the same drug as cocaine, except it's burnable now allows you to smoke it, which allows you to put it through your lungs. Your lungs have more surface area to absorb it, and you get a bigger bolus, a bigger amount directly shot to your brain. Okay, that's the difference between crack cocaine and regular cocaine. In fact, one of the most efficient ways to get any drug in the body is inhaling it. Okay, the least efficient way to get a drug in the body is eating it. When you take a pill, antibiotic, whatever, it goes to your stomach, it gets ground up, it gets hit with some acid, it goes to the blood, it goes to the liver might get rid of 80 or 90% of it, and the remainder of it goes back to your bloodstream and goes to the target organ of which it was prescribed. Okay, when you smoke a drug, it bypasses the stomach and bypasses the liver, and in this case, it goes directly to the brain, because we know that the right ventricle pumps blood back to the lungs. So it comes in the lungs, gets blood from the lungs, goes to the left ventricle eventually, and that shoots it directly to the brain. All right, let's carry on here. Depressants, and I include them all together: barbiturates, benzos, and alcohol. ETOH means alcohol. It's an abbreviation that you'll see in charts, because alcohol that we drink is ethyl alcohol. They abbreviate the ethyl as an ETOH. These depressants, barbiturates, benzos, and alcohol, agonize. And when we say agonize, that means they turn on a receptor. Antagonize means they turn off, work against a receptor. So agonize the GABA receptor, thus causing sedation, and act on dopamine, thus receptor causing addiction. Valium, Ativan, Xanax, those are benzodiazepines. Barbiturates would be phenobarbital, amylbarbital. Okay, and let me just say something here. We don't see the use of barbiturates used much anymore because the barbiturates are lethal in overdose. You could take too many and die by respiratory depression as you would with heroin. Benzos are very, very safe. In other words, benzos have a very wide, what's called therapeutic index. The therapeutic index says if you have a narrow therapeutic index, it means the toxic range of that drug is right next to the therapeutic range. The drug we can think of is digoxin, digitalis. You'll learn about that. That is a medicine that stabilizes the heart rate. But if you take too much, you can easily suppress the heart rate. Another drug with a narrow therapeutic index is lithium. We'll talk about that when we get to mood disorders. The toxic range is right next to the therapeutic range. So those drugs become a little bit tricky to regulate because you can easily get up into the toxic range. So we like to have drugs that have a wide therapeutic index, meaning the toxic range is way above the therapeutic range. Okay? Well, barbiturates are a little bit narrower. You could take too much, fall asleep, not breathe, and die. Where if you took too much benzos, that probably would not happen. In fact, I read in one of my pharmacology books that the lethal dose for a benzo is 1,000 times the therapeutic dose. So that means if the doctor gave you one pill of, say, Ativan, you'd have to take 1,000 pills to approach death. That's a pretty safe drug. You'd have to fill your whole belly up with those medicines. Okay, so again, look up the word therapeutic index. Phenobarbital, barbiturates. Anticonvulsants. Many anticonvulsants also are depressants. Okay, and alcohol is a depressant also. And again, you can die overdosing on barbiturates. You can die overdosing on opiates, i.e., heroin. Excuse me. Let me take that back. You usually will not die in overdosing on heroin. You can die in withdrawal from heroin. Okay, I correct myself. Opiates, narcotics, and this would be morphine, heroin, Percocet, Tylox, OxyContin, Roxycontin. Okay, all of them, whether they're illegal or legal are considered opiates narcotics. They stimulate the opiate receptor, and the opiate receptor, actually one of them is called a mu receptor, is for pain control. They also stimulate the dopamine receptor, causing addiction, and suppress the adrenergic receptors, causing decreased vital signs. And again, heroin, morphine, or any narcotic-based painkiller. It does not matter if it was gotten by the doctor or by the street dealer, they all fall under the same category. Again, in this case, you will not generally die under the influence if you take too much, but if you are, hold on, I got to get this clear. You can die in overdose, but you will generally not die in withdrawal. Hallucinogens. They agonize, meaning they work with the serotonin receptors. They tend to turn on the serotonin receptors. When many serotonin receptors are stimulated, the person can visually hallucinate. Okay? And that's a form of psychosis. When you're seeing things that aren't there, that's a form of psychosis. You've lost touch with reality. LSD, okay, causes hallucinations. Peyote, mescaline, ecstasy in some cases. Although ecstasy is predominantly a stimulant, it does have some hallucinogenic properties. Marijuana, the active ingredient here is tetrahydrocannabinol. It stimulates the cannabinoid receptor in the brain, which I just talked about. Tends to cause sedation, euphoria, and memory impairment. High doses can affect motivation and sex hormone levels, causing feminization in males. Okay? So it can alter sex hormones in males and females. Excess THC is deposited in the myelin sheath. Your body has the ability to get rid of about 2 marijuana cigarettes a week. You're a heavy marijuana smoker and you're smoking 1, 2, 3, 4, 5 marijuana cigarettes a day, your body can't clear that. Your liver can't get rid of it. Well, that extra THC gets deposited in fat. Okay. And that's one of the reasons why people can test positive for marijuana 6 weeks after they last smoked. Because if they were heavy smokers, that extra THC got deposited in their fat, in their brain, in their body, in their belly, all over, and it slowly leaches out, and you can test positive. Okay. The myelin sheath, this fatty covering, is a covering around the nerve that is made of fat. Okay. THC gets deposited in fat. In fact, they have done studies on heavy marijuana smokers. I read an article that there was a heavy marijuana smoker that was in a horrific car accident and passed away. They did an autopsy. They cut the top of his skull off and looked at his brain, and it was black. A normal brain, when you look at it, if you remember anatomy and physiology, is white. What we're seeing when we see the white is the fatty myelin that covers the nerves. We're not seeing the nerves themselves. We're actually seeing the fatty covering that covers them. Well, if you smoke a lot of marijuana and your body can't get rid of it quick enough, it gets deposited in your fat. And myelin is fat. So the brain of this particular person looked black due to the marijuana, the THC that's deposited, the resins. Not much different than a heavy tobacco smoker's lungs. If you look at someone who smokes cigarettes heavily and you look at their lungs, especially later on in life, you will see that they are brown and black from all the resin from years of smoking. Inhalants, nitrate-based inhalants. They usually act on GABA receptor and dissolve the myelin sheath. Okay, and these would be poppers and whippets and things like that. I'm not sure how much they used anymore. I think they were more common in the 80s. Designer drugs, we spoke about this a little bit in the beginning of this lecture. They're usually made in some kind of home laboratory with zero quality control, can vary in psychopharmacological and physiological side effects depending upon molecular structure. Extremely dangerous because of poor quality control. Ecstasy is one. Synthetic opiates, PCP, ketamine can be also, LSD, things like that. As compared to pure morphine is made from the poppy plant. Pure marijuana is made from the marijuana plant, okay? But these drugs are a bunch of chemicals mixed together many times by an amateur chemist who does not know really what they're doing, as in the case that I spoke of earlier of the guy who was making synthetic heroin and burned the molecule and gave people Parkinson's disease. So designer drugs are very, very dangerous due to a lack of quality control. Nicotine. Okay, nicotine is contained in cigarettes. Considered one of the most addictive substances known to man. Most people cannot smoke just 2 cigarettes a day, although I know somebody who smokes 2 cigarettes a day or used to. Now she smokes a little more now that her children are out of the house. She used to smoke one in the morning, and I didn't ask her when she smoked the second one. That is a joke. You can figure that one out on your own. Nicotine stimulates a nicotinic receptor. The nicotinic receptor is a subtype of acetylcholine. Acetylcholine is another neurotransmitter. We'll talk more about it when we get to cognitive disorders. Actually, acetylcholine is considered the memory neurotransmitter. Stimulates the nicotinic receptor of the autonomic nervous system. Again, if you remember, the autonomic nervous system is broken down into the sympathetic and parasympathetic, thus causing stimulation of the sympathetic and parasympathetic nervous system. Okay? Increases acetylcholine, thus increasing memory. There is some evidence, and actually I think there's some research into looking into medicines that we can give people that will increase their acetylcholine. In fact, the medicines we give to people with Alzheimer's or dementia elevate acetylcholine in the brain. We'll talk more about them when we get to cognitive disorders. Nicotine is highly addictive. It works. The nicotine activates a subtype of a nicotinic receptor. A nicotinic receptor is a type of acetylcholine receptor. It also elevates dopamine also. So it gives you dysphoria. It clears your thinking. It makes you feel better. Highly, highly addictive. Alcohol. Again, abbreviated ETOH because of the 2-carbon molecular structure. Ethyl alcohol has 2 carbons in its molecular structure. Acts primarily on the GABA receptor, but also acts on the dopamine endorphin receptor. It tends to be depressogenic. In other words, it makes you calm. But you might be saying to yourself, but when people drink, they get loud and giddy. I'll need Mangino. Right, this is my sister. I'll tell her I can't talk to her right now. Why do people get giddy when alcohol is a depressant? Because alcohol, when it elevates GABA, elevating GABA disinhibits people. In other words, it makes things people do they wouldn't normally do. They say jokes, they get giddy, they get lighthearted. That's why in early alcohol consumption, the first drink or two, people get a little giddy, get a little laughter, but as they drink more and more and more, they get sedate. Generally speaking, alcohol is considered depressogenic. Genesis causing depressogenic. Alcohol also, if you remember going back to the myelin sheath, remember the myelin sheath is the fatty covering over the nerves. Alcohol also dissolves the myelin sheath. In fact, what I used to do when I gave this drug lecture when I worked in a hospital to the drug addicts there, I'd ask one of the addicts to go get a piece of butter, a little cube of butter. I'd say, ask another one to get some alcohol in an alcohol bottle. I'd put the butter on the table. I'd take the alcohol, pour it on it, and I would say, what's happening to the butter? And the guys would look at it and say, it's getting melted away. I said, exactly. That's what's happening to your brain when you drink a lot of alcohol. You are melting away the myelin sheath. Without the myelin sheath, the nerves cannot transmit their messages as quickly, so you do things that you wouldn't normally do. Or you're slowed down and your reflexes are very slow, meaning you should definitely not be driving a car. Okay? Alcohol has a short half-life, meaning it comes out of your body very quickly, which means you can go into withdrawal very quickly. Okay? And the only way out of that withdrawal is to drink more alcohol. And that's why a person that's a heavy alcoholic literally has a drink of alcohol along with their cup of coffee in the morning. If you drink heavily until 12 midnight or 1 in the morning, fall asleep pretty easily because alcohol makes you sleep rather easily. Doesn't let you go into a deep sleep though. You wake up at 6 in the morning and you're shaking and nervous because that's the adrenaline. You elevated your GABA with the alcohol, but the GABA is gone. Now you have too much adrenaline, so you're shaking and sweating. The only way to get rid of that sweats and shakes quickly is to have another drink. Or you could take a benzodiazepine such as Valium or Ativan or something like that. So many times, heavy alcoholics must drink in the morning with their cup of coffee. Okay. Alcohol, like I said, is toxic by nature. It kills bacteria. That's why we put it on someone's skin before we give them an injection. Well, it kills your body cells also in much higher doses, of course. And your liver is always trying to get rid of it. Let's talk about the measurement of blood alcohol. Blood alcohol can be measured in 2 ways, in percent or by milligrams per deciliter. Example here, BAL of 0.08%, this is the percent of blood, which is alcohol, equals 80 milligrams of alcohol per deciliter of blood. Okay, so there's 2 ways to measure it. Easily converted, you simply move the decimal point over one place. A BAL of 40% equals 400 milligrams per deciliter. All right. The police, I believe, use milligrams per deciliter. I believe the breathalyzer uses when you go to the precinct. If you've blown positive, they bring you to the precinct. They draw blood, and I think it's measuring milligrams per deciliter. Let's talk about the effects of alcohol. Small amounts, less than 2 to 3 drinks per day. There is some benefit. It can increase appetite. Red wine aids in digestion and can increase the good cholesterol, the HDLs. Density lipoproteins, decreases the risk of macular degeneration in the eye, and possibly decreases gallstones. It may thin the blood, so it can reduce the risk of blood clots. This is small doses now, less than 2 to 3 drinks a day. Usually for a woman it's 1 and a man it's 2. Higher amounts, greater than 3 drinks per day. I just want to say here, amount people can tolerate without damage to the body can vary greatly. I've seen some people that drink a quart of vodka every day of their life, and you look at their lab values and liver function tests are fine. You look at other people that drink 4 drinks a day, and they're having an effect on their liver and other body organs. So it's very variable. But when you go above 3 drinks a day, you become to get disinhibited. Okay? And that means inhibitions means you're inhibited, you're controlled. When you're disinhibited, you can do things that you wouldn't normally do. And that results in poor decision making, such as promiscuous sex. You're out having sex multiple times a night because you're very drunk and you're not really thinking about the consequences. Okay? Alcohol disinhibits people. And I've got to be honest with you. This is why men buy women drinks at bars. They want to disinhibit the women. It could go the other way. The woman could buy a man a drink to disinhibit him. Okay? That's why, as I say when I give my lecture in rehabs, a gentleman asks a woman out for a cup of coffee at a local diner to get to know her. Because people, if you're really serious about a relationship, it's not about sex, it's about emotional connection. Okay, sex is all too easy. And sex can be a trick to make you think you like that person when you really don't, because you only know them sexually. Let's talk about very heavy use of alcohol. 5, 6, 7, 8, 10, 12 drinks a day. What happens here, let me explain first, that alcohol is an empty calorie. What do I mean by that? Well, alcohol comes from sugar. If you take sugar, put it in water, leave it out to the air, some yeast in the air will get in that little bucket of sugar juice and ferment that sugar, converting it to alcohol. Sugar is an empty calorie. What does that mean? It has lots of energy, but no nutritional value. So table sugar burns very easily. I mean, you could put a match on table sugar and it will burn very fast, but it has no protein, no minerals, no vitamins. Well, if alcohol comes from sugar, therefore alcohol is an empty calorie, meaning it has a good amount of energy, but no protein, no vitamins, no minerals. So someone who drinks heavily is getting lots of calories, but they're calories that possess no energy, no protein, no minerals, nothing. Okay? So what happens is when you're missing these vitamins, you can get what's called Wernicke-Kossikov syndrome. This is a neurological and memory change due to alcohol damage combined with vitamin, particularly thiamine deficiency. Because that alcohol doesn't have any vitamins, thiamine is a necessary vitamin. Okay? The Wernicke part here, Wernicke is the neurological changes, cerebellar and dysfunction, resulting in balance and lack of coordination problems. So someone who is a very, very heavy hitter of alcohol, as over the years, as the years go by, maybe they hit 50 or 60, they cannot even be drinking, not even be drunk, and be walking and look like they're drunk because they've damaged the cerebellum, part of their brain that coordinates balance, and they walk like they're drunk even though they're not. The Korsakoff part of this is memory impairment, okay? That you've damaged your memory, and this may truly be irreversible. Alcohol is one of the only drugs that we truly know does damage to the brain and the body. Okay? We'll talk about it. Well, we'll go back to stimulants right now. Stimulants make you spend your neurotransmitters before you really should. That's how you get high. They don't kill nerves. They don't kill nerve cells. A little like your credit card. You go to the bank, you get money out of the bank, and you keep partying, and then you put your credit card back in, and no money comes out. You still have a bank account, but there's no money there. Your brain cells are still alive, but they have no neurotransmitters to release. Okay? All right. Alcohol causes Wernicke-Korsakoff syndrome. And what we do here is as soon as these patients come up to the unit, the detox unit, which is my favorite place to work, we give them thiamine because there is research to indicate that if you give a person thiamine and maybe a multivitamin, we can reduce some of this Wernicke-Korsakoff syndrome. High doses of alcohol also kill liver cells. That is cirrhosis. Cirrhosis of the liver is scar tissue that replaces the regular tissue of the liver. It can also cause a fatty liver. Decreased blood flow causing blood backup causing esophageal varices. As your liver gets fatty, it can't process. It can't take blood in as readily. So the blood backs up. I think it backs up to the inferior vena cava, to the esophagus. Okay, the esophagus literally gets hemorrhoids within it. We don't know what a hemorrhoid is. Imagine having them in your esophagus. If they rupture and you're not in the hospital, you will spit out and bleed out blood until you die. If you're in the hospital, hopefully they can put a little balloon down your throat, pump up some pressure, put direct pressure on the varices, and prevent the blood from pouring out. Okay. High doses also cause cardiomyopathy. Fat gets deposited in the heart, causing cardiac enlargement and weakness. Cardiomyopathy. Also in high doses, peripheral neuropathy causes nerve damage due to thiamine vitamin deficiency and poor circulation. Alcohol can also decrease bone marrow production of red and white blood cells. So people that are heavy hitters of alcohol, you can look at their lab work and their RBCs and white BCs are very, very low. It can cause pancreatitis, inflammation of the pancreas. It can be chronic or acute. It can cause an alteration in hormones, decreases testosterone and estrogen, resulting in sexual dysfunction and feminization or masculinization. It can alter sleep. You may fall asleep more quickly, but you will not sleep as deeply. You will not go into what's called REM sleep. REM sleep means rapid eye movement sleep. Okay, we're seeing alcohol's not very good, is it? In high doses. Okay. Let's talk a minute about where you as nurses might meet up with alcoholics or drug addicts. Well, certainly the emergency room, certainly the detoxification ward, because they go there to get off the drugs and alcohol, certainly the drug rehabilitation ward. You may also find them on the med surg floor, because many times people get admitted for a broken leg, but they're also addicts. Okay, so they're in the hospital. They don't tell anybody that they're alcoholics or addicts. You find out after a day or two when they start to hallucinate. Okay, and again, we might see them on a psychiatric unit also, because it's not that uncommon. In fact, it's quite common. Most people that are abusing alcohol or drugs have an underlying mental health disorder, predominantly depression or anxiety. Again, alcohol is a pretty good anti-anxiety agent. The only problem is it's addictive, so you'll end up with addiction. Okay? Talk about the emergency room. What is the purpose of the emergency room of somebody coming there who's high? Well, the basic reason, let me move my chair, my back is hurting me. The basic reason is to assess if that person has a lethal dose of that drug in their body. And classically, what happens here is a couple of people are shooting heroin, and one person is nodding off, falling asleep. By the way, the rule of thumb is you never let your heroin buddy fall asleep. You put cold water on him, you burn him with a cigarette, you do something to inflict pain so he releases adrenaline, which will help him to breathe. Well, in this case, I guess that didn't work. You throw this person in the backseat of the car, you race over to the emergency room, you throw him out onto the curb, and you drive away quickly because you're afraid the nurse is going to call the police on you. They will not do that because the Good Samaritan law says that if you help a heroin addict from overdosing, we will not charge you if you're using heroin with drug use. Okay. So what the nurse does is bring this person very quickly and wants to find out what drugs do they have in their body. Okay, and the drug we don't want to have in their body is heroin or high doses of barbiturates because they can die from respiratory depression. Okay. Here, never discharge a severely intoxicated person. A person that is severely intoxicated meets the criteria of gravely disabled. And let me step back for a second. There are three reasons why you get admitted to a psychiatric unit: suicidal, homicidal, or gravely disabled. Gravely disabled means that your judgment is so off that you might do something so foolish and hurt yourself. For example, you could be in a bipolar manic phase, and for some reason you think you're the greatest swimmer in the world, and you're going to swim from Port Jefferson to Bridgeport, Connecticut. You would have to be a very, 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 very good swimmer to do that, right? So we don't want to release anybody that's gravely impaired, highly intoxicated, because their decision making is so off. Let's go on here. And I realize this lecture is long, but I hope that you have read the chapters first. You're going to listen to this lecture, then you're going to do VSIMs, and little by little, you're going to learn this stuff. Multiple exposures. Okay, alcohol in the ER. Signs and symptoms. Acute alcohol on breath. You can smell alcohol. The person's uncoordinated. They may have decreased consciousness and decreased reflexes, possible vomiting. Alcohol is rarely lethal in overdose unless used with other depressants. So if you are just drinking alcohol and you get so drunk you fall asleep and vomit, you're probably still not going to die. If, on the other hand, you shot heroin and drank alcohol, or took Valium, benzodiazepines, and drank alcohol, you could die by respiratory depression. Basically meaning your brain is so asleep, it can't tell your lungs to breathe. Okay. Physical assessment. When we physically assess these patients, what do we see? And this is usually someone who's done high dose chronic use of alcohol. As alcohol kills the liver, the person gets jaundice. Jaundice is caused by bilirubin. Bilirubin is a byproduct of red blood cell destruction by the liver. The bilirubin can't get cleared out of the body because the liver's damaged. It gets deposited in your skin and your eyes, and you see yellow eyes. Okay? Over time, when you drink heavily, you can get a bulbous nose because alcohol tends to dilate superficial blood vessels. So these blood vessels, if you are drinking all the time, can stay permanently dilated. You get this red glowing face. There was a famous comedian named W.C. Fields, long deceased, who had a bulbous nose. If you palpate their liver, the liver can be enlarged. The liver is one of the only organs in the body that will grow if it has more work to do. Well, alcohol is a poison. The liver's trying to get rid of the poison. The liver doesn't have enough liver to do it, so the liver actually grows. So you can palpate an enlarged liver. You can test for peripheral neuropathy by touching their toes. You touch their toes and you say, "Do you feel this?" And they say, "No." They have nerve damage. You can assess pancreatic tenderness. Okay. Can resemble ketoacidosis in diabetics. So do blood sugar to confirm if blood sugar is too high or low. People that are diabetics that didn't take enough insulin can metabolize their own body tissue. That produces ketones, ketoacidosis, and the breath of these people can sometimes smell a little like alcohol. So you might want to check for ketones. You can do that with a dipstick in alcohol in their urine. I don't know what happened here, but let's see. Oh, there we go. Go through all these real slow. This slide behaves differently. I don't know why. It's got a mind of its own. Okay. Interventions. What do we do for someone who comes to the ER, they're dropped off, and we have to figure out what type of drugs they did? Well, ascertain amount and types of drugs used by asking their peers. When their friends drop them out of the car, you might want to say, "What drugs did they do? Please tell us." Because that saves work, because otherwise you have to do a urinalysis or a blood draw, and that might take 10 or 15 minutes to get the results back. And they yell back, "We were drinking alcohol and shooting heroin." You go, "Okay, I got this. We know we have an antidote for heroin. We'll see that in a little bit." Okay, we can breathalyze them or do a blood draw for BAL alcohol. We can do a urine or a blood screen tox. Okay? We can assess their pulse ox to make sure that their blood saturation of oxygen of their blood is greater than 94%. If it's less than 94% or so, some people say 92, 90, you probably want to call the doctor right away, okay, especially if they're doing heroin. We might want to suction if they're aspirating, if they're vomiting and then inhaling their vomit. We want to go in the lungs and the stomach and suck out that vomit. We want to keep this person who's high, especially if they're drunk, in a low stimulus environment. These people are disinhibited. They can get agitated very, very easily. So we want to keep them in a room where the lights are dim, people are talking calmly, and things are sedate. We also can hydrate them. We can actually hook them up with an IV and get some fluid in them and actually dilute the amount of alcohol in their body. So their BAL actually goes down because now we have more fluid that's been pumped in. Okay. We could also give an antipsychotic. We can use an antipsychotic here for sedation. Well, why wouldn't we use a benzodiazepine like Valium to calm them down? Because when you mix alcohol with a benzo, you can get lethal respiratory depression. Okay? An antipsychotic such as Haldol does not cause respiratory depression, but it can still sedate. All right. Finally, here I say do not provoke the patient. Do not make them angry. They may be belligerent. They may be nasty. We don't retaliate. We don't want to provoke them. We are professional. They may say things to us that they don't like. In fact, I've had patients yell at me and say, "Your toupee looks terrible. Get a new one." My response to that is, "This hair is real, brother." Okay. We have to remember that we are the professionals. We must remain calm and in control. Because if you provoke this patient, they're going to get out of control. And now you, the nurse, have created a crisis. And when there's a crisis, we have to call other people off their units, a manpower call to control this patient. The key here is to be calm and kind. Talk about other depressants. First, we talk about alcohol. Let's talk about barbiturates and benzos. As said before, barbiturates can be lethal and overdosed by respiratory depression, like heroin. Benzos are usually not lethal in overdose unless mixed with other depressants. Signs and symptoms similar to alcohol, but no smell of alcohol. So the nursing diagnoses here would be similar to alcohol. The interventions would be similar. In other words, calm environment, don't provoke. We might have to suction out the stomach if they did barbiturates and they just didn't. We can put a tube in their stomach and suction things out. We have to be prepared to do artificial ventilation and possibly intubate, particularly with barbiturates, because barbiturates can decrease your breathing quite a bit. Again, benzos, very hard to overdose if you're just doing benzos. And again, those are Valium, Ativan, things like that. There is an antidote for benzodiazepine. It's also called flumazenil. I think another name is Ramazicon, okay, that we can give to somebody if they're really sedate on benzos. We can give them this antidote. Interesting thing, I just read the other day, I had never heard of it. Let me go back in my book here, that there's also a medicine that we can give to someone who's very drunk to help them clear the alcohol out of their system, and that medicine is called metadoxine. I read about it for the first time in my life. I've been doing this for 30 years, and I just read about it. Okay, it's probably not used very much. Because alcohol by itself, usually the person's not going to die. All right. This flumazenil, just so you know, only works for benzos. It does not work for alcohol. Talk about opiates in the ER. And it can be any opiate-based street or prescription drug, morphine, morphine sulfate continuous release, known as MS-Contin, methadone, meperidine, Tylox, Percocet, Furacet, Smack, Horse, Dope. Those are street names. Signs and similar to alcohol and other depressants, but there's no smell of alcohol. So now the person looks drunk, but doesn't smell drunk. So now you have to say, okay, they don't smell drunk, so it's probably not alcohol. So now, is it benzos, barbiturates, or opiates? The way we can tell it's opiates many times is they have constricted pinpoint pupils. So if someone looks drunk but doesn't smell drunk and has constricted pinpoint pupils, chances are they are using opiates, heroin, Tylox, something like that. That's called pathognomonic. It names the pathology. Okay? They'll also have a dry mouth. If we look on their arms, we might see track marks where they stuck the needle in, although many addicts might not use their arms. They might use their toes, their groin, because they don't want people to see their track marks. Okay? Alcohol is lethal in overdose by respiratory depression. Said. Opiates in the ER continued. Interventions, similar to barbiturates. Why? Because barbiturates are also potentially lethal in overdose. Ascertain amount of other drugs used, hopefully by asking friends. Do urine toxicology. If respiratory depression, we can give Narcan. Narcan, also known as naloxone, is the antidote for heroin. What Narcan does when you inject it is it goes to the endorphin receptor where the heroin has bound to get the person high. It bumps it off, the heroin molecule, off that receptor, binds to that receptor. But Narcan is not an opiate. It's a little like putting bubble gum in a lock. The real key can't get in because it's something else occupying that space. Well, the problem here is naloxone, Narcan, only lasts about a half an hour. And if someone is really high on heroin and not breathing, that might last 4 or 5 hours. So we have to give a shot of this Narcan every half an hour until the person is alert. You can't give one shot and say go home because the Narcan is going to wear off and they're going to go back to sleep and stop breathing. Okay? Now I can tell you, if anybody is an EMT in this class and you've ever given someone who's overdosing on heroin Narcan, they wake up in about 10 or 20 or 30 seconds and they are really angry. So be prepared that when they wake up, they're going to want to hurt you. They're going to yell. They're going to scream, "You ruined my jacket. How dare you ruin my high?" They don't think that you just saved their life. What you've done is put them in withdrawal. And withdrawal is a terrible feeling. In fact, many drug addicts, many heroin addicts told me that they barely get high when they do heroin anymore, but it keeps them from going in withdrawal. Sometimes they call withdrawal being dope sick. It's a miserable feeling. It's like having the worst flu you ever had. You're vomiting, diarrhea, shaking, sweating, irritable, cranky, you feel bugs crawling, you want to rip off your skin. So when you give them this shot of Narcan, that's what they feel. They are cranky, to say the least. Okay? Be prepared that they might strike you. In fact, I would not be surprised if this is done in an ambulance, that they actually tie the person down first before they give them that shot. Okay. We can also give them an injection of epinephrine, adrenaline, to stimulate breathing. And again, I had mentioned this a few slides back. When someone, when I work with drug addicts in rehab, they told me that, if you're doing heroin with somebody and this guy starts to fall asleep, you get your lighter out and burn his finger. You take your knuckle and put it in his sternum. You put cold ice down his back or down his pants, because what you want to do is agitate them. When people get agitated, they release adrenaline, and adrenaline helps people breathe. Okay. Patient must stay in the ER until opiates are out of their system. Have an ambu bag ready or other means of mechanical ventilation. The ambu bag is that rubber bag that you hook up to somebody's mouth or their tracheostomy and you pump it in manually. Okay. On the street, person to be kept awake and agitated by mild pain to prevent respiratory depression, and then brought to the ER ASAP. Let's talk about stimulants in the ER. And again, I realize this is a very long lecture. It's probably one of the longest lectures I've in all of this class. Signs and symptoms of stimulants. When someone's under the influence, they are hyperactive, they're hyperverbal, they're euphoric, they're tachycardia, rapid heart rate, they have increased blood pressure. They actually, when you increase that heart rate so high, the heart can't feed itself enough blood, and the person can have a heart attack. In fact, I had a patient, not his real name, who came in to the hospital, and of course the doctor does an EKG. He was a crack addict, and I get the computer prints out the EKG, and I look at the EKG, and up top of the EKG it says probable myocardial infarction. I say, Artie, come over here. What's up? What's up, Mike? What's going on, man? I say, Artie, look at this. Read this. Myocardial infarction. What does that mean? I said, that means you had a heart attack. When you're doing cocaine, dude, you're putting too much stress in your heart, and this time you did so much you gave yourself a heart attack. And the way the EKG measures that, it can measure if the cells are dead because the EKG is abnormal. He said to me 3 weeks ago, I took a really big hit of crack and I felt my whole chest tighten up, tighten up. I said, Artie, that was the heart attack you were having. You can't do this anymore. You can't do this. Again, I don't want to make him feel bad, but in reality, he's going to kill himself. Okay? And generally, that's the way people die doing high doses of stimulants, is they die of a cardiac arrest, a heart attack. Okay? Can also cause chest pain, sweatiness, as in diaphoresis, seizures, possible paranoia, and psychosis. Talk about that. Stimulants can be cocaine, can be methamphetamine, things like that. Well, those drugs cause a massive release of adrenaline, dopamine, and serotonin. Well, if you remember from reading chapter 2, dopamine is an excitatory neurotransmitter. It's the pleasure neurotransmitter. And in very, very high doses, it makes people paranoid. Okay? So they become paranoid and psychotic, meaning they lost touch with reality. In fact, when I give this drug lecture at the hospital, a bunch of patients once said to me, that's why there are tree police. And I said, what do you mean by tree police? He goes, when we used to smoke crack, we thought the police were up in the trees taking our pictures. My response was, yes, the police may be after you, but they don't climb trees and wait in the tree taking a picture. I said, now you've turned your brain into a paranoid schizophrenic brain that's thinking people are out to get you. People do stimulants because it makes them manic. When you release dopamine, adrenaline, and serotonin, you're in a great mood. You feel good. You have lots of energy. That is the same thing as the manic phase of bipolar disorder. Okay? But when you keep doing that, you rocket up your dopamine to the point of psychotic paranoia. So now you've converted your brain beyond feeling good into paranoid psychosis. People do stimulants, abuse stimulants, to feel that mania, that upbeat feeling. But what happens is those neurotransmitters get washed away, and then you induce a depression. When you come down on cocaine, you go into a depression. So basically, what you have, someone that does heavy stimulant abuse, is drug-induced bipolar disorder. Okay, let's see. You also, as you do stimulants, you dry your mouth out because when you increase your adrenaline, that puts you in fight or flight. When you're in fight or flight, your mouth gets dry, so you don't have saliva. Well, saliva helps prevent cavities, so without saliva, your teeth can rot. So if you snort this cocaine, this stimulant, cocaine and other stimulants are vasoconstrictors. So when you snort it up your nose, you constrict the capillaries that supply blood to the septum. The septum is a part of the nose that separates the two nostrils. And over time, that part, septum between the two nostrils, literally rots away from a lack of blood supply. So these people start out with two nostrils separated by a septum. After heavy cocaine snorting, months or years, they literally end up with one nostril. Okay. Amphetamines in the ER. And this is still under stimulants. Ascertain amount and type used, decrease stimulation, induce vomiting if the drug was taken by mouth, gastric lavage, meaning gastric suctioning stuff, suctioning out the stomach, do an EKG. We can give the person a benzo, a Valium, or an Ativan to calm them down and prevent a seizure. Because people can also die from stimulants, not only from a heart attack, but from a seizure. Because stimulants elevate excitatory neurotransmitters, which turns the brain on. And when the brain is turned on too much, you can have a seizure. We can give a beta blocker. A typical beta blocker is Inderal. What a beta blocker is the medicine blocks the beta adrenaline, also called adrenergic, the beta adrenergic receptor. Well, the beta receptors regulate blood pressure and heart rate. Well, if we block those receptors, the adrenaline can't get to it, so their heart rate goes down, as does their blood pressure. We can hydrate the patient, and the absolute last resort here, if the person's out of control, is we may have to restrain them. That is an absolute last resort. As I told my students in my first clinical group on Thursday, that before you restrain somebody, you better have tried other means of behavioral control that have failed. And in your note, you write down these other things you tried that failed, and you had no other choice to restrain them. In mental health care, our notes are our legal defense in the court of law. A broken leg, we can see a leg is broken. It's obvious this person's got a problem. Their leg is broken. Here's what we do to fix it. The judge can see that, Mr. So-and-so, your leg was broken. But the judge can't see what the behavior that person was demonstrating before we had to put them in seclusion or restraints. We have to document the behavior we saw, how we tried to control that behavior, talking to the patient, offering alternative ways of coping. Let's watch a movie, let's exercise, let's read a book together, something. He can offer a PRN, he doesn't take it, he's still threatening the staff. We are forced to put the patient in restraints. Okay, let's talk about marijuana in the ER. It is uncommon to see in the ER unless mixed with other drugs. Marijuana causes lethargy, some euphoria. We can see dilated pupils and reddened conjunctiva. possible anxiety and paranoia in a novice user, or some of the strains I've heard nowadays, marijuana can be very, very powerful. And in very high doses, it can cause some psychosis and paranoia. Okay? What do we want to do? A very low stimulus environment, dim the lights, talk in a very calm, supportive voice. Something like, this will pass, this will go away, you're not going to die. I know you're a little afraid now, but I'm here with you. You're going to be okay. If this calm, reassuring talking doesn't work, we can offer the person a sedative, maybe a benzodiazepine such as Ativan or Xanax or something like that. But usually these patients usually don't end up in the ER. And if they do, they're probably novice users or did some very powerful marijuana, and just some reassurance that they're going to be okay. Of course, we want to make sure there's no other drugs in their system. We want to get a urine tox, things like that. But if it's just marijuana, it'll probably pass in a couple of hours. Okay. Well, now we're out of the detox ward, out of the ER. Now the person has got admitted to the detoxification ward. So the purpose of this ward is to assist in the safe withdrawal from drugs. Withdrawal from drugs is opposite of its intoxicating effect. So if someone's doing a stimulant, by the time they get to the detox ward, usually been in the ER for a couple of hours and the drug's coming out of them. By the time they get to the detox ward, they're in withdrawal. So whatever the drug was doing, we're going to see the opposite. If they were doing a stimulant, i.e. cocaine, they're going to be tired and sleepy. If they were doing alcohol and were sedated down in the ER, they're going to get nervous and sweaty and shaky and agitated up on the detox floor, because usually it's a couple hours by the time they get there. The nurse that works in the detoxification ward should create a milieu. The word milieu means environment. It must be a French word, milieu. Should create an environment that is understanding, compassionate, and attractive to the patient, so the patient sees sobriety as a positive experience. Remember, the detox ward is really the first unit they're coming in to spend the night. If the nurse is nasty and blaming, you know what they say to the patient? F you, the world sucks, I'm leaving, and I'm going out to get high. On the other hand, if the nurse says, hey, I know you're having a rough time here, but you're in the right spot. I give you credit for being here. It takes courage to be here, and I'm here to help you. I'm here to get you well so you can have a great life. That's the goal here. Not a cranky, nasty nurse. We don't want to do that, because you'll do more damage than good. If you feel the little voice in your head says, I hate these patients, I hate these patients, I hate these patients, you either got to go to therapy and talk to a therapist about that and find out why, or you need to leave that area where you work. No matter what area you work in, it doesn't matter. It could be a chemotherapy unit. If the little voice in their head says, I hate working here, you need to talk to somebody about that or ask for a transfer to a different unit, because what happens is you do more damage to a patient than good. There is recent research that indicates that empathetic, caring nurses help a patient get better. In other words, if the nurse is cranky, irritable, and versus a nurse that's kind, and patients are getting the same medical treatments, the nurse that is kind has better outcomes. So our attitude as a nurse toward our patients directly influences how they or if they will get well. Remember that. People burn out working in the same spot year after year. Fortunately, as nurses, we can ask for a transfer to a different area. That's the beauty of nursing. You're not pigeonholed to work one area the rest of your life. I know a couple of nurses at Stony Brook that through a 30-year career had worked on 15 different units. Oncology or orthopedics, OBGYN, psychiatry, the ER. They'd work there for a year or two, and when they got kind of a little tired and burnt out, they said, let's go somewhere else for another challenge. Okay, let's get back to the lecture. We have to create an environment that is kind and compassionate. The way I describe it is, we have to make this detox experience like honey. The saying goes, you catch more flies with honey than you do with vinegar. because this is the entry point for these people. And if we're nasty, we just reinforce their belief that they're bad people, no one likes them, F the world, I'm going to go out and get high. On the other hand, Mr. So-and-so, come sit down, let's have a cup of coffee together. Let's talk. Let me hear, how did you get here? Oh, yes, I could see that would be difficult. Your father died last year and you started drinking heavily. Oh, boy. Did you ever go for any grief counseling? No, I didn't go. Well, maybe you can think about that. That's the way we have to be as detox nurses. Patients tend to be irritable, cranky, and demanding, making good communication and psych nursing skills essential. Remember, they are giving up their lover. Another analogy I think about that works pretty well in addiction is giving up the best lover of your life is rather difficult. Okay? Giving up the best lover of your life is rather difficult. My phone is ringing. I will ignore it. No one wants to give up that best lover. And that's what the addict is doing. They're giving up a drug that got them over all the stress of life, all the difficulties of life. When they were in a difficult position, they got high or they drank. To ask somebody to give that up abruptly is very, very difficult. Okay? So we have to have compassion for them, that they're doing a job that's very, very difficult. Okay. In the detox ward, safety is the #1 priority. That's why they're there, because they need to be observed. Okay? Our job is to have the patient realize he will need more
Hi,
treatment.
Mr. Mangino. It's Dr. Giuliano. Have your results. I'll be in the office all day Wednesday. If you want to call me then at 631-642-0609. Thanks. Have a good day.
Okay, that's my doctor calling. Don't have time to talk to her, though. Okay, let's go on. Well, it used to be that mental health professionals, especially in addiction, used to
Unknown caller.
beat. This is crazy. Isn't this crazy? Used to beat patients into sober. You must get sober. You must get sober. You must get sober. That's called confrontational interviewing. Now we do what's called motivational interviewing. A person comes into the detox ward and we try to find out from them why they want to be sober. Avoid confronting, which usually results in resistance and decreased chance of behavior change. Motivation for change is elicited from the client, not from the therapist. We might ask the patient, what goals does patient want to achieve by being sober? How is drug use interfering with achievement of these goals? So we're making the patient think about why they want to be sober. So they want to get sober for themselves, not for us. And I put those slides in this area because it's in the detox that the patient's going to make a decision whether to go to rehab or to go leave the hospital again. Okay? All right. Alcohol in the detox. What are we going to see? Well, someone's going to be in withdrawal when they get in the detox. Onset usually several hours after the last drink, but may be delayed up to several days due to severe adrenergic and dopaminergic neurotransmitter release. So the symptoms of withdrawal that we see from alcohol are caused by lots of adrenaline and dopamine being released. Remember, there are excitatory neurotransmitters. Well, what they do is they increase your pulse, they increase your blood pressure, they make you sweat, they give you anxiety, you get agitated, they make you shake. Untreated, they can have seizures. Okay? Progressing to delirium tremens. Delirium tremens is you're delirious, you don't know where you are, you might not know who you are, and you're shaking, also known as the DTs. Okay? We don't see that very much because we've gotten so good at treating patients in alcohol withdrawal. Patients in the DTs typically feel like there are bugs crawling on them. Okay, that's called a tactile hallucination. And again, when you guys come to the detox ward, we're going to go over all of this again. Can also have visual hallucinations and delusions. If untreated, patient can die by stroke, seizure, or cardiac arrhythmias, or circulatory collapse. How does that happen? Well, let's look here. You have a stroke because your blood pressure is so high, you rupture a vessel in your brain. You can have a seizure because your brain is super activated by adrenaline and dopamine. It has no ability to calm itself down. You can have cardiac arrhythmias due to adrenaline dopamine, and you can have circulatory collapse because your heart is pounding so fast it can't fill itself up with blood. So it's basically an empty stroke. Your blood pressure collapses and you die. What do we do? Well, what we do is we replace their drug alcohol with a drug that works very similar in their body, and that class of drugs are called benzodiazepines. Okay? The drug of choice to treat an alcoholic, the most commonly used drug, is called Librium. The name of that drug, excuse me, I'm making a mess here. The name of that drug is called Chloridized Epoxide. Most benzodiazepines end in AM, alprazolam, clonazepam, diazepam. Okay, this one is an outlier, chloridized epoxide. Okay. Well, we can't start giving that Librium, that chloridized epoxide, until their BAL is less than 200. Why? Because if their BAL is 200 or higher, and we give them a benzo, we could induce respiratory depression where they stop breathing. So what will happen is they will have had blood taken down in the ER. Okay? You'll get a number when they come up with what their BAL in the ER was. If it was above 200, you have to wait until it gets 200 or less before we can give them this Librium. Let's look here. Let me go back. Alcohol is consumed at about 20 milligrams per deciliter it's excreted from the body at about 20 milligrams per deciliter per hour. So if someone came in with a BAL of 300, we would have to wait 5 hours. 5 times 20 is 100. 100 from 300 is 200 to bring the BAL down to 200, and then we can give them a benzodiazepine. Okay? Well, again, we want to ascertain amount, type, and duration of alcohol and drugs used. How long were they doing this? How much were they doing? Okay. What I have found, higher amounts, longer duration, and older age, usually there is a more severe withdrawal. Okay. I have found you could have a kid that's 25 years old. He's a heavy hitter. He comes to detox. He gets a little anxious, a little sweaty. A day later, he's good to go. You get a man who's 65 or 70, been drinking heavily for 50 years. He is probably going to go through a much more difficult withdrawal than the younger person. Interventions, bed in low position. If someone's going to fall out of a bed, make it a low one, right? And that's in every area of nursing. When you do med surge, when you go into that patient's room, you make sure their bed is as low as it can be. We want to encourage the patient to lie down. We want to hydrate them. Low light, low stimulation environment. We may have to assist with ADLs because if they're really impaired, they're not going to be able to take care of themselves. They may not have showered in a long time, or they're shaking so bad they can't feed themselves. Okay? We want to do vital sign ASAP upon entry to the unit because the baseline, the vital sign gives us a baseline of where they're at. If their blood pressure and pulse are really, really high, that's an indication they're going through a rough withdrawal, and we might want to call the doctor right then and there. We want it treated with Librium or other benzos per LIP order because of cross tolerance. So alcohol and benzos work very similar, so we replace their alcohol with a benzo. Well, 20 or 30 years ago, patients would get admitted to detoxes, and the doctor would say, give the person 50 milligrams of Librium every 2 hours until sedate. When they wake up, give them 50 more, and wake up, give them 50 more. When I come in tomorrow morning, the doctor will say, I'll lower the dose. That's kind of inaccurate. Well, about 20 or 30 years ago, I believe it was developed in Canada, there's a tool that was developed called Clinical Institute Withdrawal Assessment. This tool is developed to quantify alcohol withdrawal symptoms from alcohol and indicate the need for Librium or other benzodiazepine. It assesses the patient's withdrawal symptoms, rates them on a scale of 0 to 7, score of greater than 8. The patient usually receives benzos. Now, the doctor in that hospital can make that threshold, could make it 10, could make it 8, could make it 12, threshold where the person's going to get medicine. In this case, it's 8. The person gets a score of 8, they can get Librium 50 to 100 milligrams or Ativan if the liver is impaired. Okay? Cross tolerance, since the patient is tolerant to alcohol, they can tolerate very high doses of benzos. Like I said a few slides back, excuse me, another motorcycle, I live on a busy road. Someone who's drinking alcohol very, 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 very heavily could tolerate massive doses of benzos. Most of us, if we took that high dose of benzos, provided we're not alcoholics, which I hope we're not, we would sleep for 3 days. But since this person is tolerant to alcohol, which means they're tolerant to benzos, they can tolerate much, much more, much higher doses. All right. Well, here are the areas that we assess on that SIWA tool I talked about. We ask them, do they feel nauseous? Have they vomited? We have them stick out their hands and look for a tremor. We ask them if they have what's called paroxysmal sweat. Paroxysmal means acute onset, out of the blue, they just start sweating. Look at their forehead. I feel the palm of their hands. We ask them, do they feel if there's any bugs crawling on them? We ask them if our voice appears very loud. We ask them if the light seems very bright or are they seeing things. We ask them, do they feel nervous? Or I sometimes ask them, do they feel like they're trembling inside? Are they agitated, pacing, sweating, can't sit still? We ask them if they have a headache or if their head feels full. We will also assess them for orientation. Do they know where they are? Okay. What hospital they're in, what date it is, things like that. Each of those areas gets a score out of 0 to 7. We tally it up again. If the score is above 8 or 10, they'll probably get a benzodiazepine. Here's the moral of the story. SIWA is only used for alcohol withdrawal. It is the tool that measures the severity of the alcohol withdrawal symptoms, and depending upon the numerical score they get, that will dictate the dose of medicine they're going to get. Well, some patients, if they are severe alcoholics, may live at a BAL baseline of 250, which means this person is just constantly has alcohol in their blood, which means they may show withdrawal symptoms at a BAL level of 200, which means we cannot give them Librium. So this becomes a predicament. Someone is a heavy, 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 heavy hitter. I mean, they drink from the morning they get up to the minute they go to bed at night. And they're probably drinking 20 beers or 25 shots of whiskey a day, more. They're going to show withdrawal symptoms above 200, right? But from what I just told you, you can't give them Librium because you might cause respiratory depression, because when you mix Librium, a benzo, with alcohol, you can depress the brain to tell the lungs not to breathe. Okay? What do? We are in a predicament now. They're showing symptoms of withdrawal, but their BAL is not below 200. What do? You call up the doctor and you say, doctor, this patient's BAL, according to my calculation, is still 240, but the guy is shaking and baking. He can't sit still. He's dripping with sweat. His vital signs, his blood pressure is 210 over 120. His pulse is 126. What the doctor will probably do is say, give him 1 milligram of Ativan and call me in an hour. Watch him very, very, very closely. Okay? The point here is we don't just tell the patient, I'm sorry, I can't give you any medicine because your BAL is too high. So if you have a seizure, sorry, no, we can't do that. We have to call the doctor. All right. Alcohol. Patient is hallucinating. Antipsychotics should be avoided. Why? Because antipsychotics can make getting a seizure easier. Okay, and they're already prone to seizures. That's why we give benzos, because benzos also help prevent seizures. Okay, because when you elevate GABA, which benzos do, GABA is an inhibitory neurotransmitter that turns off the nerves in the brain, When you turn the nerves off in the brain, you have a less chance of a seizure. Okay? If patient is requesting meds but is not demonstrating withdrawal symptoms, now what should you do? Oh, his BAL is 0. He's not showing any withdrawal symptoms, but I'm requesting medicine. Mike, I gotta have medicine. Mike, I'm feeling nervous. Mike, oh my God, you gotta give me something. Mike, please, please give me something. What do? I get the CWA sheet. I ask him the questions on the CWA sheet, which we just discussed. His score will probably be well below 8, which means I can't give him medicine. And I'm assuming his vital signs are stable. Okay. I tell this gentleman, Mr. So-and-so, I can't give you medicine because your CWA score is too low. I'm not allowed to, but I will come back in 15 minutes and do this again. And if your score is higher, I can give you medicine. But I can assure you, I am not going to let you suffer unnecessarily. You're not going to have a seizure. I am on your side, but I just can't give you medicine because I will get in trouble. Okay? If we have a therapeutic alliance with a patient, and that therapeutic alliance means the patient trusts us, right? We've won them over. They realize that we're not against them, which many psych patients seem to feel. They say, okay, Mike, I trust you. I'll lay down in bed and I'll try to calm down. Okay, Bill, I'll stop back in 15 minutes. We're going to check again. And if you need it, you're going to get it. I'll be back in a bit. Let me go work with some other guys now. In other words, a supportive tone. We are never against these patients. This is the fun of working the detox ward. The patients are angry. They're upset. They're angry at themselves. They're angry at the world. They're going to project that anger onto us. And they're looking for a reason to get angry. So when we're so calm and kind and compassionate, you'll find at first they don't trust you. They say, this is a trick. What's this person doing being kind to me? I'm a bad guy. They got to be mean to me. But over that tour, they realize that you're on their side, and they will tell you, thank you. You were kind to me. You helped me today. And I say, it's okay. I'm here to help you. I'll be back tomorrow. I once had a patient come in. He called me an a-hole. I looked at him and said, but you don't even know me yet. Oh, you're just an a-hole. I said, I might be, but you don't know me yet. By the end of the tour, he looked at me and said, you're all right. You're all right, Mike. And I looked at him and said, so are you, dude. You're okay, too. That's the fun of working in this area. Okay. So as patients, if patient gets through their detox, the detox of alcohol takes about 3 to 5 days. As patient clears, we educate patient of the benefits of rehab and maintaining long-term sobriety. Mr. So-and-so, you've done very well here in rehab, in detox. You could have left any time you want, and I'm proud that you stayed. You know, when you get out there in the world again, it's going to be hard not to go back to do drugs and alcohol because they're very tempting. So I really think you should go over to the rehab ward. You'll learn how to stay off drugs and alcohol and learn other ways and other things you can do to calm down, such as exercise, things like that. So patients should go to rehab after the detox ward. Depressants in the detox. Lecture is a long one, like I told you. People coming off of barbiturates and benzos, withdrawal can be fatal. Okay? If you are habituated, in other words, an addict, to either depressants, they would be Seconal, Tuinal, things like that, Quaaludes, or benzos, you've done them maybe for more than a month heavily. If you stop taking them abruptly, you can die. Very much the same way you can die coming off of alcohol. Okay? With a seizure, a heart attack, something like that. Signs and symptoms usually appear after several days of long-term high-dose use, or several weeks. Withdrawal is similar to alcohol. There's a great propensity for seizures here. Okay? Nursing diagnoses are similar to alcohol, and I took the nursing diagnoses out because you guys won't be doing much of them until you get to RN school. But I have to tell you, if you know this lecture and know this book, you will roll through mental health in RN school. Okay. Depressants in the detox ward. Nursing interventions, similar to alcohol. Assess amount and type use, duration use. By interviewing the patient. Give IM Valium, have IM Valium ready for seizures. You must have a Valium IM ready for seizures because you can't give it by mouth because the person's seizing, right? You have to inject it IM. Anti-seizure drug may be added to further reduce chance of seizures. So people that are coming off of, say, barbiturates or benzodiazepines, is the doctors will usually put them on a very long-acting benzo, and one of that is Klonopin. And they might also add to them an anti-seizure medicine such as Depakote. Depakote's an anti-seizure just to make sure they don't have a seizure. Opiates in the ER. Withdrawal from opiates are uncomfortable but rarely life-threatening. These withdrawal symptoms usually occur 6 to 8 hours after the last dose. Hold on a sec. The withdrawal lasts between 7 to 10 days. It feels like you have a terrible flu, body aches, nasal congestion, vomiting, diarrhea, chills, restlessness, shaking, elevated vital signs, goosebumps, also called cold turkey. You have a wicked flu. You may wish you were dead, but you won't. Okay? In fact, insurance companies say we don't want to admit patients coming off of opiates to the detox ward because they can go home and stop doing the drug on their own. They will not die. The chance of any opiate addict making it through that horrible withdrawal for 7 to 10 days without going out and getting heroin to get rid of these symptoms is almost zero. So there are nurses, their sole job in the hospital is to argue with insurance companies to get payment for people coming off of opiates. The insurance company, no, let them go home. They can just go home and lay in bed for 7 days. We know they're going to go out and buy drugs. So that these addicts should be very thankful because if the insurance company does not pay, the hospital eats that bill. If the hospital eats enough bills, that hospital goes out of business. So when I give a lecture to the detox patient, or the rehab patients, which you'll see, I actually tell them, you should thank the doctors and nurses here because they're admitting you, realizing this hospital may not get paid for your care. They do it out of humanity. Most of the time, the insurance company does pay because what happens is without treatment, with severe diarrhea and vomiting, you get what's called an electrolyte imbalance. You throw off your salt balance in your body. Well, without a proper salt balance, your heart can't contract properly and you can have a seizure. Okay, so that's the way they get you in for electrolyte imbalance or dehydration. That's what the insurance companies pay. Okay, nursing diagnosis similar to alcohol. Interventions. Offer emotional support. This will pass. Make the person comfortable. Allow as many showers as desired. When I worked in a hospital, you can take a shower for 15 minutes. The guy go in there for 15 minutes, knock on the door. I say, Mr. So-and-so, you have to come out here for at least 15 minutes because there might be another guy waiting. So he would come out. Someone else would go in. He would go back in. And I said, I don't care how many showers you take. I'm not paying the heating bill. But you do have to share the shower with other people that want to take showers also. So the limit was 15 minutes. We can also give an antihypertensive drug called clonidine. We'll talk about that in the future a little bit also. And what that does is it decreases the release of adrenaline. When you decrease the release of adrenaline, you decrease agitation and anxiety in these patients, and they calm down, and their withdrawal is a little bit easier. We can give a medication called Bentyl for stomach cramping. We can give Motrin for body aches, or we can actually replace their opiate with either methadone, which is a prescription opiate, or Suboxone, which is also a prescription opiate. Okay, methadone was invented by Bayer aspirin during World War II because Hitler did not have access to poppy plants because it was in a cold climate. So Bayer, a German company, developed synthetic heroin, which is basically methadone. A more recent drug is called Suboxone. It is a mixture of buprenorphine and Narcan. Buprenorphine, as in morphine, has an opiate type effect, replaces their heroin, We give them that medicine and we slowly decrease the dose over several days as their withdrawal symptoms get less and less and less. Let's talk a little bit more about methadone and Suboxone. So methadone and Suboxone are both opiates. They can be used for pain control. Methadone is a very good pain control medication, as is Suboxone. The advantage with Suboxone is not as lethal an overdose as heroin or methadone, so it can be used for pain control. It can be used for opiate withdrawal, which I just spoke about in the previous slide. Or if a heroin addict keeps relapsing, they've been to the detox ward 6 times in a year, the doctor says, look, you've been here 6 times in a year, you've gone to rehab 3 times, our interventions are not working, you continue to relapse. I'm not blaming you, but you have a very strong illness here that is not responding to treatment. I'm going to offer you, doctor offers to the patient, methadone maintenance. What does that mean? That means the patient will go to a county clinic. There's one in Riverhead, Hauppauge, and Huntington every morning at 7 o'clock, and he will get a low dose of methadone, not enough to get him high, but enough to keep him out of withdrawal, which means he can go get a job and pay taxes and raise a family. In fact, I worked with a nurse in a hospital who was a Vietnam vet. Again, very high use of opiates over there. Picked up a heroin habit while in Vietnam, went to rehab, could not stay off it, was on methadone maintenance, became an LPN, worked on the unit with me, the mental health unit, and he was great. He understood addiction. He understood emotional pain. He was great. Okay. Well, Suboxone came out about 20 years ago. So it's quite a bit safer because it's not lethal in overdose. Also with Suboxone, remember it's got Narcan in there. If you take it by mouth, the buprenorphine part of this drug acts like methadone in your body, goes to the opiate receptor in your brain, keeps you out of withdrawal. You can go to work. But if you take that Suboxone and decide, I'm going to get high, I'm going to inject it with a needle in my vein, Narcan part, which is the antidote for heroin, goes to the heroin receptor in your brain, endorphin receptor, does not let the buprenorphine bind to it because the Narcan binds with greater binding ability, and you don't get high. Suboxone is better than methadone because methadone, you could crush up that pill, liquefy it, and inject it and get high. If you do that with Suboxone, you're not going to get high because Suboxone has Narcan in it. And the Narcan is only active when it's put in IV. It's not active when taken by mouth. So Suboxone is very, very clever. Again, I would look up Suboxone to get more background on it. Woohoo, this will end eventually. I'm getting tired myself. Stimulants in the detox. So again, they're coming off it. Not life-threatening unless they're suicidal. Remember, stimulants make you feel good. You feel happy. You feel hyper. Life is great. I love life. Life is fantastic. Hey, we can party all night long. This is great. I love life. And then your neurotransmitters that were elevated from the stimulant, they get washed away, and now you go into a depression. Life's terrible. Life sucks. I hate it. God, this is terrible. The quickest way out of that is to do more of a stimulant. Okay, let's see. Not life-threatening unless suicidal. Prone to suicide because they used up their excitatory neurotransmitters, which are the feel-good neurotransmitters, and they go into a depression. The result here is severe fatigue. Make sure I got everything. Is this going to work here? Severe fatigue and lethargy, depression, irritability, and possible suicidal ideation. So if someone's coming off of stimulants, especially crack cocaine, we probably want to put them very close to the nurse's station to make sure they're not going to harm themselves. Interventions. We want to monitor for suicidal ideation. We actually ask people, do you have thoughts of harming yourself? If they say yes, I'm going to jump out that window any second, or the minute you walk out of this room, I'm going to hang myself on my bed sheet. we probably want to call the psychiatrist and get them transferred to the psychiatric unit, which is a locked unit. We want to remove all dangerous objects, anything they could use to harm themselves. We want to encourage that patient to sleep as needed, offer hydration, water, juice, nutrition, things like that. People that are stimulant addicts tend to be very, 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 very skinny because stimulants act like an appetite suppressant, so they don't eat much. Marijuana, we really don't see marijuana in the detox because marijuana has such a long half-life. It stays in your body so long that it really doesn't have abrupt, serious withdrawal symptoms. There are some withdrawal symptoms from if people smoke marijuana heavily and then abruptly stop. They may have some anxiety, some insomnia, but usually not worth it getting admitted to the hospital. Oh, well, let's talk a little bit. I love working the detox ward. It was my favorite place to work in all of my nursing career. Why? Because the patients come in angry, upset, irritable, cranky, mad. And my job is to win them over, let them know I'm on your side. This addiction is not your fault, although it is your responsibility to get well. If you want to be sober, this is the illness you have. Someone else might have cancer. Someone else might have diabetes. Someone else might have asthma. You have this disorder, and I'm here to help you with it. Okay, a little story. I was working in the VA, in the detox ward. An older World War II vet came in. Apparently, he had tried to stop drinking on his own. By the time he came into the hospital, he was already in severe DTs, delirium tremens. He was hallucinating. He was incontinent, defecating on himself, peeing on himself. He was in a jerry chair, all tilted back. I would have to feed him and change his diaper. He would think there was cats coming across the floor. He was having visual hallucinations. Meanwhile, in the back room are a couple of Vietnam vets coming off of heroin, vomiting, puking, screaming, girl, I can't do it. Oh my God. So this guy, the World War II vet, says, I have to go to the bathroom. So these two other Vietnam vets that were doing pretty well, now they were out there watching TV, they come over to me and say, we'll take this World War II vet. I'll call the World War II vet Joe. We'll take Joe to the bathroom. You go help our buddies in the back coming over here. And I said, okay. I said, but you got to promise me. If you get him up, you can't drop him. Do not drop him. If you drop him, I'll be doing paperwork for the rest of my life. Half a joke there. So they got him up, walked him to the bathroom. He could barely walk, this guy. One guy had each shoulder. They get him in the bathroom. Before they put him in the bathroom, they put down his pajamas, his Depends, sit him on the toilet, and stand outside the door like guards. I'm coming in out of the room, getting out, helping this guy, helping that guy. I go by, I say, how's Joe doing? They open up the door. They, Joe, how you doing? I'm doing good. He's doing good, Mike. I say, good. Keep your eye on him. Okay. You done, Joe? Yeah, I'm done. They pick up Joe off the toilet, wipe his bottom. They put on a fresh Depends, which is another name for diaper, but we don't call it a diaper, we call it a Depends. They pull up his pajamas, they walk him back to the chair, and they set him down. That was the best day of my nursing career. Why? Because I believe I created a milieu, an environment of caring and compassion. They saw me running around like a chicken without a head. They rose up and said, we will help you, Mike. We will help you. Let us take this man to the bathroom. You do your work with our buddies that are coming off of heroin. In fact, I wrote this story and submitted it to the American Psychological Association, APNA, American hold on. The APNA, American Psychological Nurses Association. I'm a busy guy today. I don't know what's going on here. And they actually published it. One of my students found it about 5 years ago and said, is this you? Let me just let this phone ring. Hang on. Hold on. Okay, here we go. So I created an environment that was warm and caring, and these other veterans saw that and they wanted to rise up and help me. And that's exactly the goal we want to have in drug rehab and detox, that we are all in this together. My job is to create an environment. My job is to create an environment that demonstrates compassion, okay? Not blame, not anger. Anyway, that's right. Well, these two dynamics to care. That's okay. Okay, so the next area that you're going to see patients is the drug rehabilitation ward. The purpose of this ward is to give the patient the tools to maintain long-term sobriety. Patients interview for acceptance and must be motivated for long-term sobriety. If they're not motivated for sobriety, they should not be coming to this ward. Okay? It is a voluntary unit. If they are mandated by the courts, they can still be kicked out off the unit. So in other words, you don't just get in because you want to. You get in because you meet the criteria that you're really serious about being sober. The drug rehab ward should address any pertinent patient issues, drug and addiction education. In fact, you guys will see me giving my lecture on addiction to those patients. Anger management, sober socialization skills, coping skills, hobby development, past traumatic and childhood events, because many of these addicts have had trauma in childhood. Unfortunately, as lengths of stay have been shortened, there is less time to address past trauma. Rehabs used to be 6 months, then they were 3 months, and now they're 28 days. Rehabs and any hospital stay is very, very, very expensive. So insurance companies are paying less and less and less, so the times have been shortened. So we assist patients developing better coping skills. We educate about drugs and addiction. We create a milieu of camaraderie and support by role modeling, like I did in the detox ward. We emphasize importance of 12-step meetings, going to AA and NA. We encourage verbalizations of thoughts and feelings. We capitalize on their strengths. We give them kudos for doing the right thing. We instill a sense of hope that through work and self-discipline, life will get better. Again, the basic tool all humans have to solve their problems in life is called self-discipline. What does that mean? It means doing something I don't want to do, but I have to do it. For example, you guys want to become nurses. You have to discipline yourself to study. The result of that discipline will give you a better life in a couple of years. Okay. Well, another great time on the rehab unit. You might remember this patient, Artie, a fictitious name. He's a guy who had a heart attack on the detox unit many slides back. Well, he was at the rehab, and he was a tough guy. He was a tough guy, no doubt. Big guy, tough guy. Well, there's a pool table at the end of the hallway in the rehab unit, and I hear some couple yelling or something. This guy comes walking up. He's got a bloody nose. I say, "What happened to you?" He goes, "That guy down there, I beat him in a pool game, and he punched me." I look down, and it's Artie. Artie, okay. All right, no problem. I call the doctor. I say, "Doctor, one patient assaulted another here. I think this patient that did the assaulting needs to be discharged to the street. It's 11 o'clock at night right now." She says, "Mike, do what you have to do." I call the VA police. They come to the unit. I say, "Artie, to the front desk." He goes, "What do you have up, man? What's up? What's up?" I said, "Artie, you just punched this guy." He lost the game. He thought I was cheating, so I punched him." "Artie, you get physical here. It's no longer me nursing. It's police. I just called the doctor. Pack your bags. They're escorting you off the grounds." Kicked them out of the VA at 11 o'clock at night. Well, about a year later, I'm still working in that unit, and guys on that unit go down a couple of buildings to go to dinner. And after dinner, there's always an AA meeting. They come back to an AA meeting or an NA meeting, Narcotics Anonymous, either one. And I'm sitting on the stoop, and the guys are coming in, filtering in, and I see this guy walking toward me. It's Artie. I said, "Artie, what are you doing here?" "I'm here to run the meeting." "You can't run this meeting. You got to be sober for a year." I am sober for a year, Mike. How did you get sober? I went to CK Post on the grounds of Pilgrim State, and I'm sorry I did that last time to that guy. I'm really sorry, Mike. I'd like to speak here at this meeting tonight. Well, I almost get teary-eyed. Stood up, I gave him a big hug. I said, "You've been sober a year, man." "Yeah, I have been." I said, "Come on, and you run this meeting." He walked down that hall, and he was about as vivid as you could be. I heard him saying, "You want to get sober, you listen to that guy Mike and those doctors, they want to help you. You don't want to, you can get the F out of here." I'm going, "Oh my God." But the guys appreciated that. When I kicked him out that night, I was afraid. I said, "Am I doing the right thing? Is this the right thing to do?" I mean, the doctor concurred with me. It's inappropriate behavior. But, the last thing I wanted to go out and have the guy do drugs. But he didn't. He went over to CK Post and got well. You know, we are kind. We're very kind to these people. And when they see us get angry at them, like a mother, if you're kind to your kids and you get angry, they must have done something seriously wrong, right? He came back and he was as proud as a peacock. "Mike, I'm going to beat this." Well, about a year later, I was working in detox and already got admitted. Already, what happened? I thought I could do crack just one more time. I thought I could. Already, crack is like potato chip. You just can't eat one. You can't do that. Got sober, left, got back to work, doesn't punch anybody. He takes responsibility for behavior, and he comes in when his illness is getting out of control. That's progress. That's progress. Okay? So we don't measure progress by being sober forever. We measure progress by relapse times getting shorter and sober times getting longer. Okay? Okay. Well, something I want to add here is many of these patients are arrogant. Okay? And arrogance is really a defense mechanism against shame. A dog that barks a lot is kind of arrogant. Okay? They're arrogant because they want to chase you away. They've been hurt. So instead of showing their hurt and their emotional pain, they act like tough guys. Already acted like a tough guy until he realized it's okay to be human. It's okay to show your emotional pain. Okay? So when you see someone who's arrogant, it doesn't mean they're bad. It means that they're suffering. They're only using arrogance to keep the world away from them. And through kindness and empathy, we can win them over. And they can come around like Artie did, to take responsibility for their behavior, to accept their illness, to not blame it on others, okay? And to rejoice in getting well. Okay, another story on detox. Dietary aids coming up and giving out the food trays. Food tray in front of this patient, lifts up the top of the food tray and says, "Oh, this food is crap. I'm not eating this. This is garbage." The food worker comes over and says, "What do you mean?" He goes, "This is garbage. This is terrible food. I'm not eating this." Looks up at the food guy and goes, "You wouldn't know what it's like. You don't know what it's like." He goes, "I was in your chair a year ago. Yesterday you were in a cardboard box living on the street. Now you have a beautiful warm bed and good food. It may not be the food you want, but at least you have food. I was in your chair a year ago, and now I work here." So when the aide was walking off the unit, I said, "Thank you so much. You did more than I could have done." Because many times in hospitals, people that got sober can come back there and work in that hospital. Okay. I apologize for this lecture being so long. Again, you can turn it off and take a break anytime, but I got to keep going. There are medications that are used to assist in sobriety maintenance. Let's talk about some of those medicines. There's a medicine called Antabuse. It's known as disulfiram. Basically, what it does is it makes you allergic to alcohol. If you drink alcohol, you'll become nauseous and possibly vomit. You'll have a headache. It can lower your blood pressure, known as hypotension. It can cause tachycardia, increased pulse rate, dyspnea, known as shortness of breath, chest pain, and dizziness, known as vertigo. So Antabuse, known as disulfiram, is given to alcoholics to make them allergic to alcohol. If they drink the smallest amount of alcohol, they will feel lightheaded and dizzy and nauseous and vomit, okay? The problem here is excessive mixture of both alcohol and this disulfiram antabuse can result in cardiovascular collapse, myocardial infarctions, and death. Not that common, but it could occur. So antabuse, disulfiram, is known as aversion therapy. They avert the drug. They avoid it. Okay? The problem is there are some side effects, possibly death. So we don't like to use it so much anymore because we have better medicines now. Let's go on to the better medicines. Revia. This is called naltrexone. It is very similar to, it is the PO version of naltrexone. It's very similar to Narcan. Narcan's naloxone. Except Narcan lasts a half an hour. Naltrexone lasts about 6 hours. It is the antidote for opiates, usually given by mouth. Okay. The IM version is called Vivitrol. It is the new hot drug. It fits in the opiate receptor, but it does not activate it. So it looks like heroin, but it's not heroin. Okay? So it goes in there, and it's like putting bubble gum in a lock. The real key can't get in there. So if someone is on this medicine and either does heroin or alcohol, both interesting enough, they do not get high. The problem is if they keep shooting enough dope, they will overwhelm the naltrexone by sheer numbers of molecules and get high, and then they can get so high they can die from respiratory depression. So it's a tricky medicine, but it's very, very good. The way it works in alcohol is obviously alcohol, now we realize, releases some endogenous opioids. It releases endorphins. Okay? Decreases endogenous opiates effect of alcohol, thus decreases some of the pleasurable effects of alcohol. So if an alcoholic is taking this medicine, Revia, PO, or Vivitrol IM, and they drink, they don't get that warm and fuzzy feeling they like to some degree because it's not allowing the release of endorphins. Okay? The full mechanism of action is unclear. In fact, when you look up many psychiatric meds, it says just that. Something like the full mechanism of action has not been fully elucidated, but it is theorized that it works in such and such a way. Very hard to see how these medicines work in the brain. Methadone, we spoke about that. Used to when patients cannot stay off of opiates, can be put on methadone maintenance. We talked about that. You can also use Suboxone in a very similar way to keep them off it. Can also be used for pain. I do want to say that this is not naltrexone. That should be naloxone. My bad. Well, another place you may very well see patients that are alcoholics or addicts is the med-surg floor. Okay? Because people break their arms, break their legs, get sick, and they have a drinking or a drug problem. They come in, and unless the nurse asks them, they're not going to admit it. Because many people are ashamed about how much they drink or how much drugs they do. Patients admitted to the med-surg floor may not reveal their drug problem, thus may demonstrate unexpected withdrawal symptoms. Now what's doing, up until about 15 years ago, med-surg units, nurses, didn't usually ask a patient if they had a substance abuse history, alcohol consumption, drug consumption, okay? Now we ask them on intake if they have a problem. And again, if someone's drinking, saying they drink 2 drinks a day, you might want to call the doctor just to get an order of a CIWA order. That's the Clinical Institute Withdrawal Assessment. Okay, just to get that order. So you can give them Librium if they start demonstrating withdrawal symptoms. All right. So we have to ask them if they have a drug or alcohol problem upon admission. And most people downplay the amount of the drug they're using. Some people say we can double what they say they do. I don't really like to do that. But I will, if they say, 2 or 3 drinks a day, I'll just call up the doctor or the psych NP and say, look, this guy's, he's saying he drinks 2 or 3 drinks a day, but just in case he goes into withdrawal, I don't want to have to wake you up when you're sleeping downstairs. Why don't we go to CIWA protocol? This way I can give him Librium and not have to wake you up. And the doctor says, yeah, okay, that's a good idea. All right, let's go. Med-surg floor. Again, we're going to act non-judgmentally. We're going to ask how much they take. We're going to assure that everything they tell us is confidential. Nothing gets revealed because of HIPAA. Okay, we just had this orientation at the hospital last Thursday, and I emphasized to the students, you cannot have mental health care without confidentiality. No one is going to reveal their personal thoughts or their addiction to you if they think you are going to blurb it out through society. So the HIPAA is very, 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 very strict for mental health care, especially care of addiction, because there is a big stigma against addiction. Okay. Again, greater than 3 drinks a day, you want to call that doctor for CWU. We want to follow the protocol for other drugs and substances. Most hospitals have a protocol for coming off of all drugs. Each hospital, it could be a little different. You'll learn that when you get there. Okay. Well, there is a little tool we use, a little verbal tool we can use to help us assess someone's drinking. It's called CAGE. Ever felt the need to cut down on your drug use or drinking? A, annoyed by people criticizing your drinking. Feel guilty about your drinking. Do you need an eye opener in the morning to calm your nerves? If the patient says yes to any of these, there's a good chance they have a substance abuse issue, particularly if they say they need a drink every morning to wake up. That shows that they are addicted to alcohol. Well, non-medical aids for sobriety. 12 Steps, Alcoholics Anonymous, 12-step program, Alcoholics Anonymous, is a fellowship of men and women who share their experiences, strengths, and hope with each other that they may solve their common problem and help others to recover from alcoholism. The only requirement is a desire to stop drinking. So you can go to AA drunk. You only need a desire to stop. And if you go there drunk and the other people are sober, they see how they might look like when they're drunk. And it might reinforce their sobriety. Okay? So the only thing you need to go to 12-step meetings is a desire to be sober. Boy, isn't that being non-judgmental, right? Well, let's talk about the impaired professional. It is a known fact that doctors, dentists, and nurses have a greater incidence of substance abuse. Why? We are under tremendous stress and we have drug availability. All drug use is considered self-medication for emotional pain. I have never met a human that doesn't use some substance. Virtually every one of us in the morning gets up a little tired and has a cup of coffee. That's self-medication. Some of us at night come home from work and have a drink to relax. That's self-medication. Okay? Again, 10% of the population loses control of that and goes into full addiction. Dentists, physicians, and nurses have a higher incidence of professionals who have similar education level. I think that's higher incidence of addiction I meant by that. Nurses have an ethical and possibly legal responsibility to report suspicious behavior. Meaning, if you see one of your coworkers appear high, you have to report it to your boss. Okay? Now your boss has to make a decision. Are they high? Are they high? Are they not that high? Because again, if you charge somebody with addiction, you could potentially destroy them. In fact, destroy their career, right? In fact, there was a case in Nassau County. A driver was driving erratically. The police pulled him over, arrested him for driving under the influence, took him into the clinic, charged him with, driving under the influence. It turned out he was a diabetic. He had not taken his insulin that morning, so he went into ketoacidosis, got lightheaded, drove a little erratically. His breath smelled a little like alcohol, so they assumed he was drunk. He countersued and won, saying, "You've charged me with a crime that I didn't do. It was caused by my diabetes." The point I'm making here is if we are going to accuse somebody of being impaired, you better be sure that you're right, because you can destroy this person's career forever. So, we may see somebody, but you want to make sure that's up to your boss because you're not going to do it. It's up to your boss. Unless somebody is so sloppy drunk, that's a different story. That's clear as day. But some people might say that there's not enough data for me to take the stand here because I'm not really sure. Let me observe more, something like that. Always remember, this can damage somebody's career. Okay. Let's see here. Nurses have an ethical and possible legal responsibility to report suspicious behavior, such as poor work performance out of the norm for that individual, frequent absenteeism, especially a no-call, no-show, unusual behavior for that person, signs of impairment, slurred speech, unusually euphoric, etc. Unusual isolation from peers. In other words, the nurse just disappears for an hour and you can't find her or him. Impaired nurses have the right to treatment like any other member of society, okay? Just because you're a nurse, doctor, whatever, dentist, doesn't mean that you are entitled to treatment like anybody else. I told my my nursing students this past Thursday, I am a SPAN nurse. I used to run a group for nurses that had drug problems, and that SPAN stands for Statewide Peer Assistance for Nurses. New York State Nurses Association considers drug use and alcohol use excessive to be an occupational hazard. Nurses are under tremendous pressure. So it's self-medication. So what we try to do, what will happen is if you're caught at work high or you're caught stealing opiate from a patient and you're caught, what they'll probably tell you is they'll either make you resign, which is not a great thing to do. They should report you to the state. They make you resign and you think you got away with it. But they did call the state up. And 6 months later, you get a letter in the mail. And it says, it's come to our attention on such and such a date, you diverted such and such a medicine from such and such a patient. Please report to New York City or Albany on such and such a date to discuss this matter. You go in there and they say, here's what we're going to do. You are going to go to SPAN and you're going to go to AA or NA, whatever, for 2 years. After 2 years, you will have the full use of your license back. If you do not do that, we will put your name on the internet that you, nurse so-and-so, diverted medicine from a patient to get high. If that happens, you'll never get a job again, right? Because when your background checks that you guys had done, look into that, okay? So what nurses would do is they'd come to SPAN very upset and angry, and my job as a clinician here is to calm them down, saying, look, it's okay, you have this disorder, you have this illness, you're doing the right thing, you can get your license back, you can get back on track. It's going to take some work, and I'm here to help you, okay? That's called SPAN. I urge you, or any other nurse you know, if you have a drug or alcohol problem, to contact me. Everything is confidential. I will hook you up with the agency SPAN to help you get treatment. Because the last thing you want to do is work your butt off for this LPN degree and have it taken away from you. You have an illness that wasn't treated. That would be terrible. So please, please, please talk to me. Everything is confidential. I want you guys to have great careers. Okay? So you're monitored for about 2 years, and if you do everything right, you're good to go after that. Let's go here. A couple of miscellaneous things, and I think we're done here. If kids don't get high until the age of 19, they have a much less chance of becoming addicts. That makes total logical sense. Because by the age of 18, hopefully you've learned effective coping mechanisms. You get angry at somebody, you go for a bike ride. You get depressed, your girlfriend breaks up with you, you call up a friend and go out to dinner and talk. But kids at 14 and 15 have not developed that. So when they start doing drugs at 14 and 15, they are emotionally stunted. I think I said it in a previous slide. You can have a man who's 50 years old with the emotional maturity level of a 14-year-old because he's been doing drugs since he's 14 and never learned how to solve problems. Okay? Well, I would say to the addicts, God gave us two drugs, sex and food. Enjoy them both responsibly. Drug addicts are classic neurotics, which means they are great candidates for education. A neurotic is someone who does the same behavior over and over and has anxiety and neurosis. All of us are a little neurotic. Okay? The drug for the addict is their hobby, lover, and God. No wonder they don't want to give it up. Alcohol is yeast byproduct. I'll let you read that word. One of the greatest joys of working in this area is watching the shame of addiction be replaced by the pride of sobriety. Just like Artie, when he came back to run the meeting on the unit, he came up and he was so proud. And I said to him, "You can't run this meeting. You haven't been sober for a year." And he said, "Mike, I am sober for a year. I'm here to talk. How'd you get sober?" "I went to CK." He was so proud that he had controlled his illness. Let's see if we have another slide. Conclusion. Substance abuse and dependence is a universal problem that affects all strata of society. At no time should the person be shamed or humiliated, as used to be done in the older, what were called therapeutic communities, also known as TCs. They were based on shame. We don't shame anybody who has an illness. We don't shame anybody with diabetes. We don't shame anybody with cancer. This is a genetic, biologic illness. There is no blame, but there is responsibility. They may want to blame their parents. They may want to blame people. And my response is, yes, we can blame our parents for our cancer and our asthma and our diabetes. But ultimately, God gave us a brain to solve our own problems. We do not expect to cure the illness of addiction. We hope their sober periods get longer and their relapses get shorter. See if we have any more. This is the end of this lecture. Quite a long lecture. I apologize. See it in a few sections. If you have any questions, feel free to email me. I prefer to be emailed or called during my office hours, Monday and Wednesday. But if you're really antsy and you need to, you can shoot an email right now. Okay, I'll try to do another one probably tomorrow because I'm pretty wiped out right now. And you guys have a good one. Okay? Bye-bye.